Hey guys, tonight we are stepping into a world where a simple toothache could ruin your entire year, where the most advanced dental technology available was a pair of strong hands and a willingness to pull hard, and where the inside of the average human mouth was, frankly, a catastrophe in progress. Tonight we are talking about medieval dentistry, or rather, the magnificent, horrifying, occasionally hilarious absence of it. You are going to drift off to sleep knowing things about toothworms, barber surgeons, and rat skull remedies that you absolutely did not know when you woke up this morning, and honestly, that feels like a fair trade. Fair warning though. If you are someone who gets anxious at the dentist, the world you are about to enter will make your modern hygienist with her little mirror and her gentle scraper seem like an absolute angel sent directly from heaven. You probably won't survive this, at least not with all your teeth intact. So, before you get comfortable, take a moment to like the video and subscribe, but only if you genuinely enjoy what I do here. And as always, drop a comment telling me where in the world you are watching from and what time it is there. There is something genuinely lovely about knowing that someone in Auckland and someone in Oslo and someone in a very tired suburb of Chicago are all drifting off together, learning about medieval tooth extraction. We are all in this together, friends. Now, dim the lights, maybe turn on a fan for that soft background hum, and let's ease into tonight's journey together. You are standing in a small English village sometime around the year 1200. The air smells of wood smoke and damp earth and something vaguely animal that you have decided not to investigate too closely. It is morning. You have just woken up on a straw-stuffed pallet that has seen considerably better days, and before you have even fully opened your eyes, you are already aware of a familiar, dull, insistent throbbing in the back of your jaw. It has been there for 3 days now. Yesterday it was manageable. Today it has graduated to the kind of pain that makes you seriously reconsider every decision that has led you to this moment. Welcome to daily life in the Middle Ages. Welcome to your teeth. The story of medieval dentistry is not really a story about dentistry at all, at least not in any form you would recognize today. It is a story about pain and endurance and the remarkable human capacity for just sort of getting on with things despite an almost total lack of effective solutions. It is a story about folk knowledge and religious belief and the strange intersection between medicine and magic that characterized most of pre-modern healthcare. And it is, occasionally, a story that is genuinely funny in a deeply uncomfortable way, which is more or less the ideal combination for a bedtime history. Let us begin at the very beginning, which is to say, let us begin with the mouth itself. The average medieval person's mouth was not doing well. Archaeological evidence, and yes, people have spent serious academic careers digging up medieval skulls and examining their teeth, which is the kind of dedication that deserves enormous respect, tells us that dental decay was extraordinarily common across all levels of medieval society. Skeletal remains from excavations across Britain, France, Germany, and the wider European continent consistently show high rates of caries, which is the clinical term for tooth decay, as well as evidence of abscesses, tooth loss, and periodontal disease, which is the kind of gum disease that, left untreated, causes your teeth to essentially loosen and fall out on their own schedule, without anyone needing to pull them. Now, you might assume that medieval people had terrible teeth because they ate badly, and you would be partially right, but the full picture is considerably more interesting than that. The medieval diet was genuinely varied depending on your social class, your geographic location, your religion, and the season, and the relationship between what people ate and what happened to their teeth is one of those areas where historians and archaeologists and dental researchers have been productively arguing with each other for decades. But we will get much deeper into the diet question later, because it deserves its own long, winding, slightly unsettling conversation. For now, let us simply note that the medieval mouth was a place of ongoing negotiation between a person and their pain, and that the tools available for managing that negotiation were, to put it as charitably as possible, limited. What did medieval people actually do about tooth pain? The honest answer is that most of the time they endured it. This is not as strange as it sounds from our modern vantage point. Pain was, for most people throughout most of human history, simply a condition of existence. You did not necessarily expect to be free of pain. You expected, at best, to find ways to make it tolerable enough that you could continue working your fields or tending your livestock or doing whatever it was that kept you and your family alive. A toothache was unpleasant, certainly, but it was competing for your attention with a fairly impressive roster of other unpleasant things. including seasonal hunger, the ever-present threat of infectious disease, the genuine physical demands of agricultural labor, and the minor constant discomforts of living without central heating, indoor plumbing, or any of the other things that make modern life as comfortable as it is. That said, medieval people were not simply passive in the face of dental suffering. They were actually remarkably creative and resourceful in their attempts to address it. The range of remedies available to someone with a toothache in the medieval period is genuinely staggering, spanning from the sensible and mildly effective to the deeply peculiar to the kind of thing that makes you wonder exactly what the person proposing it was thinking. We will spend considerable time on those remedies, because they are frankly wonderful. But first, let us think a little more carefully about the basic situation, what medieval people understood about their teeth, and what oral hygiene, such as it was, actually looked like on a day-to-day basis. Here is a thing that might surprise you. Medieval people were not entirely ignorant of the idea that teeth needed some form of maintenance. Medical texts from the period, drawing on a tradition that stretches back through Arabic medicine to ancient Greek sources, acknowledged that the mouth required attention and that neglecting it had consequences. The influential tradition of Galenic medicine, which dominated European medical thinking throughout the medieval period and beyond, understood the mouth as a site where the body's internal humors, those famous four fluids, blood, phlegm, yellow bile, and black bile, could become imbalanced, and where the results of that imbalance would manifest in decay, pain, and loss. This is not how we would frame it today, obviously, but it represented a genuine attempt to build a coherent explanatory framework for what was clearly a universal human experience. Teeth cleaning, in some form, was practiced. The most common method was simply rubbing the teeth with a cloth, often combined with various powders or pastes made from substances that ranged from the genuinely abrasive and mildly useful, ground chalk, for instance, or fine sand, to the more exotic, including mixtures involving burnt rosemary, powdered sage, and in some recipes, ground-up animal bones or shells. These tooth powders served a broadly similar purpose to modern toothpaste in that they provided some mechanical abrasion to remove surface debris, though their chemical properties were entirely different and their effectiveness considerably more variable. The toothbrush, as we know, it did not arrive in Europe until the late medieval or early modern period, imported from China where bristle brushes had been in use for centuries, and even then it took considerable time to become widely adopted. In the meantime, the cloth and powder method, or simply rubbing with a finger, was what most people had. Toothpicks were genuinely popular and widely used across social classes, which is charming in its own small way. Archaeological finds include toothpicks made from bone, wood, metal, and quill, and there is textual evidence suggesting that carrying a personal toothpick was considered a mark of reasonable personal hygiene rather than an affectation. Some medieval households had small combined tools that functioned as both toothpick and ear scoop, which is the kind of dual-purpose design that suggests a pragmatic approach to personal care that you can only respect. There is actually a lively scholarly debate here. Historians still argue whether the frequency of tooth cleaning in the medieval period varied significantly by social class, or whether the basic practices were broadly similar across the population, with only the materials used reflecting differences in wealth and access. Some researchers suggest that certain monasteries, with their emphasis on bodily discipline and regulated daily practice, may have actually maintained better average dental hygiene than the surrounding secular population, simply because monks had access to written medical traditions and a structured daily routine that included attention to personal cleanliness. Others push back on this, pointing out that the monastic diet, which often included significant quantities of bread and cooked grains, may have offset any hygiene advantages. Meanwhile, back in your small English village, your toothache is not getting any better. You have tried pressing your tongue against it, which has not helped. You have tried ignoring it, which has definitely not helped. The left side of your face is beginning to feel slightly swollen, which is either nothing or very bad news, and you are sensible enough to be worried about which one it is. Because here is the thing about medieval toothaches that separated them from the merely unpleasant and pushed them firmly into the genuinely dangerous. An untreated abscess, a pocket of infection at the root of a tooth, was not just painful. It was potentially lethal. Dental infections that spread to the jaw, the throat, or the soft tissues of the neck could and did kill people in the medieval period, and while we do not have precise statistics, There is enough evidence in both textual sources and skeletal remains to know that this was a real and recognized danger rather than an abstract theoretical possibility. This is the thing that really reframes your understanding of medieval dental pain when you sit with it for a moment. A toothache today is an inconvenience. You call your dentist, you get an appointment, you might spend a day or two uncomfortable before someone with a proper numbing agent and a set of sterile tools fixes the problem for you. In medieval Europe, that same toothache was playing a longer, more dangerous game. Every day it persisted without effective treatment was another day the infection had to spread. Another opportunity for a bad situation to become a much worse one. People knew this, at least instinctively, if not in the precise bacteriological terms we would use today, and it gave dental pain a particular quality of dread that went beyond the immediate physical experience. So what were your options? If you were a peasant in that English village, your first recourse was almost certainly the accumulated folk wisdom of your community. The remedies passed down through families and neighbors, the local healer or wise woman who knew which plants helped and which prayers to say, the practical knowledge that represented centuries of empirical trial and error compressed into the daily management of pain. We will spend significant time on those remedies in a later section, because they genuinely deserve it. But your second option, for more serious cases, was to seek out someone with the tools and the willingness to actually intervene physically, to go, in other words, to whoever in your area was doing the closest thing available to dental work. And that, in the medieval period, was almost certainly the barber surgeon, which is where things start to get really interesting. The figure of the barber surgeon stands at one of the great intersections of medieval social history and medical history, and understanding who they were and what they did is essential to understanding how dental care, such as it was, actually functioned for most people in medieval Europe. They were not doctors in any formal sense. They were not trained at universities, which in the medieval period were exclusively focused on theoretical medicine based on ancient texts and had a profound institutional snobbery about actually doing things with their hands. The barber surgeon occupied a strange middle ground, trained through apprenticeship rather than formal education, licensed, in some places some of the time, by craft guilds rather than medical faculties, and practicing a form of medicine that was explicitly physical and manual, cutting, draining, stitching, pulling, in a world where the learned physicians considered such work beneath their dignity. They cut hair, they shaved beards, they bled patients, which was one of the most common medical procedures of the entire medieval period, based on the Galenic understanding that many illnesses resulted from an excess of one of the four humors and that removing blood was an effective way of rebalancing the system. They lanced abscesses and dressed wounds and performed minor surgeries, and yes, they pulled teeth. The red and white striped pole that still marks barbershops in many countries is a direct descendant of this tradition. Red for blood, white for the bandages, the pole itself representing the stick that patients gripped during bloodletting procedures to encourage the blood to flow. Every time you walk past a barbershop, you are walking past a small monument to medieval medical history. Tomorrow, or rather, in the next section, since we are drifting gently towards sleep and there is no tomorrow yet, only this soft, unfolding present, you will meet the barber surgeon properly. You will see his tools, which are exactly as alarming as you are imagining. You will sit in his chair, which is less of a chair and more of a bench or stool or sometimes just a spot on the floor where he tells you to sit. You will understand, with a vividness that will hopefully remain pleasantly theoretical, exactly what tooth extraction looked like before anyone had thought of anesthetic. But for now, just stay in that village. Feel the weight of that dull jaw pain. Watch the morning light come through the single window and let yourself appreciate, in a warm and drowsy way, the particular luxury of living in a time when you can simply pick up your phone and make a dentist appointment. The contrast is not meant to alarm you. It is meant to comfort you. You have options that the most powerful king in medieval Europe did not have, and that is a genuinely lovely thing to carry with you into sleep. The medieval world was not without its ingenuity. Its people were not without their compassion or their cleverness. They did the best they could with what they had, which is all any of us do, really, across any stretch of history you care to examine. But what they had, in the realm of dental care, was genuinely quite limited, and the gap between what they needed and what was available to them produced a centuries-long improvisation that is alternately fascinating, poignant, and deeply, comfortably strange. Your jaw still aches. The wood smoke is drifting. Somewhere outside a rooster is making his opinions known about the early hour, and the village is slowly beginning to stir around you. You have a decision to make about that tooth. You are not going to make it just yet. For now, you are just going to lie there in the gray morning light, pressing your tongue experimentally against the sore spot, and think about your options. Rest here for a moment. Let the century settle around you. We are just getting started. The thing about living with dental pain in the medieval period is that it shaped your relationship with your own body in ways that are genuinely difficult to imagine from where you are lying right now, comfortable and horizontal, with access to ibuprofen and a dentist's phone number. Pain, in the medieval framework, was not purely a medical problem. It was also, depending on who you asked, a spiritual one. The Christian theological tradition had a great deal to say about suffering and its meaning, and dental pain was not exempt from this interpretive framework. There are medieval texts that treat toothache as a punishment for sin, not necessarily a dramatic sin, not the kind of thing that gets you excommunicated, but the everyday accumulation of small moral failures that characterized ordinary human life in the medieval understanding. If your tooth hurt, it was at least worth considering whether you had recently been uncharitable or dishonest or insufficiently devout, because the body and the soul were understood as deeply interconnected systems, and disruptions in one were often read as symptoms of problems in the other. This might sound discouraging, and in some ways it was, but it also had a practical upside. It gave people a set of spiritual remedies to deploy alongside their physical ones. Prayer, obviously, was available to everyone at all times, free of charge, and required no special equipment. There were specific saints associated with dental pain whose intercession you could invoke. Saint Apollonia is the most famous of these. She was a Christian martyr from Alexandria in the 3rd century whose legend held that her teeth had been knocked out or pulled out as part of her persecution, and as a result she became the patron saint of dentistry and toothache sufferers throughout the medieval period and beyond. Prayers to Saint Apollonia, the wearing of small amulets associated with her, and visits to shrines or churches that claimed to possess her relics were all understood as legitimate and potentially effective interventions against dental pain. Whether or not you find this persuasive from a medical standpoint, it is worth noting that the placebo effect is a real phenomenon with measurable physiological consequences. And a person who genuinely believed that Saint Apollonia's intercession was reducing their pain may well have experienced something like relief, or at minimum, the psychological comfort of feeling that they had done something, that they were not simply helpless in the face of their suffering. That feeling of agency matters. It always matters. One of the recurring themes you will notice as we move through the medieval dental world is that people were relentlessly, sometimes desperately inventive in their attempts to manage pain and maintain some sense of control over their own bodies. The remedies could be strange. The theories could be wrong. The outcomes could be, to modern eyes, somewhere between ineffective and actively counterproductive. But the impulse behind them, the refusal to simply accept suffering without attempting to address it, is one of the most recognizably human things about the entire story. Back to archaeology for a moment, because the physical evidence is genuinely fascinating and it is worth pausing on it. When researchers examine medieval skeletal remains with attention to dental health, they find a picture that is considerably more nuanced than the simple narrative of universal medieval tooth decay might suggest. Age matters enormously. Younger individuals in medieval populations often show relatively good dental health, with decay rates increasing significantly with age, which maps reasonably well onto what we would expect given a lifetime of dietary exposure and no effective dental intervention. Geography matters too. Coastal populations who ate more fish and less grain sometimes show different decay patterns than inland agricultural communities. Monastic communities, whose diets and daily routines were carefully regulated and documented, provide some of the most interesting comparative data, with some studies suggesting that certain monasteries had populations with notably higher rates of decay, possibly because the monastic diet included more honey and cooked carbohydrates than the average peasant diet, even if it was also more regular and reliable in terms of caloric intake. Sex differences in dental health are another area of active research. Some studies of medieval skeletal populations have found that women show higher rates of certain types of dental disease than men in the same communities, which researchers have linked to the physiological demands of pregnancy and lactation, which can draw calcium from the mother's body and affect dental health, as well as to possible differences in diet between men and women in certain medieval contexts. This is an area where historians still argue about the interpretation of the skeletal evidence, partly because the evidence itself is sometimes ambiguous and partly because the social and dietary variables are complex enough to make clean conclusions difficult. What all of this archaeological evidence shares is a quality of intimate testimony. These are real people's real teeth, preserved in the earth for centuries, still carrying the evidence of the pain they experienced and the lives they lived. There is something quietly moving about that, if you let yourself feel it. Somewhere in a museum collection or a research archive, there is a medieval skull with a tooth that hurt exactly the way your teeth have hurt at their worst, and the person who lived behind that skull did not have any of the things you have to help them. They had their faith and their folk remedies and their barber surgeon and each other. They had, in short, the things that humans have always had: improvisation, community, and an enduring refusal to simply give up. The morning is fully arrived now in your imagined village. The rooster has made his point and moved on to other concerns. Someone is moving around in the next dwelling, and you can hear the familiar sounds of a medieval morning beginning: the creak of a wooden door, the distant lowing of a cow, the thin, high voices of children being directed toward their chores. Your tooth still aches with that maddening, rhythmic insistence. You are going to have to do something about it. But not just yet. For now, let the sounds of the medieval morning wash over you, soft and distant, and let your own breath slow down to match the unhurried pace of a world that did not have alarm clocks or notification pings or any of the sharp modern interruptions that ordinarily pull you out of the soft half-space between waking and sleep. You are drifting backward through centuries, gently and safely, and there is nothing to worry about here except a toothache that isn't even yours, belonging to a person who has been at rest for 800 years. Let that be a comfort. Let the distance of history do what it does best, which is to transform even pain into something strange and interesting and, ultimately, peaceful. We have a long journey ahead of us through the medieval mouth, and all of it is waiting quietly on the other side of this particular moment of stillness. The barber surgeon does not look like much, standing there in the morning light outside his small shop on the edge of the market square. He is a compact man, maybe 40 years old, with forearms that suggest he has spent a significant portion of his life doing things that require grip strength, and an apron that you are trying very hard not to examine too closely in terms of its staining history. Above his door hangs the striped pole you now recognize for what it is, that red and white spiral that in your century means nothing more alarming than a haircut, but in this one means something considerably more multifaceted. There is also, in some versions of this scene, a small basin hanging alongside the pole, and possibly a row of teeth strung on a cord or displayed in some other fashion, which served as a kind of advertisement, a proof of professional experience, a way of saying to passers-by, "I have done this before, and the evidence is right here, and yes, those are real. You are here because your jaw has been swelling for 2 days, and the folk remedies you have tried at home have done precisely nothing. You have held a hot cloth against your face. You have pressed cloves into the sore area, which actually helped a little, and we will discuss why later. You have said the appropriate prayers to Saint Apollonia and meant them sincerely. None of it has resolved the underlying problem, which is that somewhere in the root structure of your back lower molar there is an infection that is not going to get better on its own, and some part of you, the pragmatic part that keeps you alive in a world without antibiotics, knows that the tooth is going to have to come out. So here you are. The barber surgeon's workspace is modest but not chaotic. He is a craftsman, and craftsmen tend to have an organized relationship with their tools, even when those tools are alarming. Along one wall there is a collection of instruments on a shelf or hanging from hooks, and this is where your gaze is inevitably drawn and where it would probably prefer not to linger. There are blades of various sizes, because bloodletting is still the most common procedure he performs on any given day, and you do not bleed someone with enthusiasm and imprecision. There are needles and thread for stitching wounds. There are the long, thin instruments used for probing and cleaning. The dental profession has always had a slight obsession with poking at things to see what happens, and this predates modern dentistry by centuries. And then there are the extraction tools, the pelican, the dental key, the simple forceps or pliers that, in less well-equipped hands, might just be actual pliers from a blacksmith's workshop, repurposed with the pragmatic flexibility that characterizes medieval medical practice at every level. Let us talk about those tools, because they are genuinely remarkable objects and they deserve your attention, even if your jaw is already tightening sympathetically just thinking about them. The pelican was one of the most widely used tooth extraction instruments of the medieval and early modern periods, and it got its name from its shape, which was thought to resemble the long beak of a pelican. It consisted of a curved metal shaft with a rotating tip called a claw on one end and a bolster, a stabilizing piece that rested against the adjacent tooth or jaw on the other. The basic operating principle was leverage. The bolster provided a fulcrum, the claw engaged the tooth, and the operator used the mechanical advantage of the device to rock the tooth loose and extract it. In theory, this was more controlled and less traumatic than simply grabbing the tooth with pliers and pulling. In practice, the results varied enormously depending on the skill of the operator, the condition of the tooth, and the specific anatomical situation involved. Teeth with deep or curved roots, teeth that had partially fused with the surrounding bone, teeth that were decayed to the point where the crown might break off during extraction, leaving the root behind. All of these presented challenges that the pelican handled with varying degrees of success. The dental key, which would become the dominant extraction instrument in the later medieval and early modern period, worked on a similar leverage principle but with a different form. It looked, as its name suggests, somewhat like an old-fashioned key, with a handle and a rotating claw head that could be fitted over the crown of a tooth. The operator would position the key, apply pressure against the jawbone with a bolster, and then rotate the handle, using the torque generated by that rotation to loosen and extract the tooth. The dental key remained in common use well into the 19th century, which tells you something about either its effectiveness or the conservative nature of dental instrument design, or possibly both. Then there were the simpler instruments. Forceps of various designs, essentially specialized pliers adapted for dental use, which required more direct pulling force but offered the advantage of simplicity and reliability. A skilled operator with good forceps and a clear understanding of dental anatomy could perform extractions that were, by medieval standards, reasonably efficient. The problem, of course, was that medieval understanding of dental anatomy was imperfect, that medieval forceps were not standardized the way modern instruments are, and that medieval operators ranged from the genuinely skilled and experienced to the almost entirely improvised. Because here is the thing that the guild system, for all its organizational ingenuity, could not entirely solve. The quality of barber surgeons varied enormously. The guild structure meant that in major cities, London, Paris, Bologna, Bruges, there were established practitioners who had served proper apprenticeships, who had accumulated years of practical experience, who knew what they were doing in the reasonably competent sense that any skilled craftsperson knows their trade. But in smaller towns and rural areas, the situation was considerably more improvised. A traveling tooth puller who set up in the marketplace on fair day might have varying levels of actual training, and the medieval patient did not have Yelp reviews to help them make an informed choice. The traveling tooth puller deserves a moment of dedicated attention, because they are one of the genuinely colorful figures of medieval and early modern medical history. These itinerant practitioners moved from town to town, setting up in marketplaces and at fairs, and combining dental extraction with a kind of performance that was part medical procedure and part entertainment. The extraction of a tooth in a public market setting was, by necessity, a spectacle. You needed to attract customers, you needed to demonstrate your skill and your confidence, and you needed to do so in a context where the potential customer could see other people apparently surviving the procedure, which was reassuring in its own limited way. Some traveling tooth pullers employed musicians to play during extractions, ostensibly to cover the sounds of the procedure but also contributing to the general carnival atmosphere that made the whole event feel slightly more like entertainment and slightly less like the medical emergency it often actually was. Some had assistants who would mingle with the crowd and perform enthusiastic testimonials about previous successful extractions. The line between medicine and theater in this context was genuinely blurry, and historians still argue whether the theatrical elements of itinerant dental practice were primarily about distraction, marketing, or some combination of the two that its practitioners might not have been able to cleanly separate themselves. There was no anesthetic. This point bears sitting with for a moment, because it is so fundamentally different from any dental experience you have had or are likely to have that it requires a genuine imaginative effort to really absorb. The barber surgeon had no way to numb your mouth before he went to work on it. The concept of local anesthetic, of injecting a substance directly into the tissue to block the nerve signal from a specific area, would not exist for centuries. What was available was a range of substances that could be taken internally and that might, if you were lucky and the dose was right, reduce your overall sensitivity to pain or make you sufficiently drowsy that the procedure was less acutely terrible than it would otherwise have been. Alcohol was the most obvious and widely available option. A patient who had consumed a significant quantity of ale or wine before a tooth extraction was not going to be pain-free, but they might be sufficiently blurred around the edges that the experience was at least somewhat more survivable. The barber surgeon himself might also have a drink before the procedure, though ideally not quite as much as the patient, since the procedure required a certain amount of manual precision that excessive alcohol consumption did not improve. Beyond alcohol, there were herbal preparations that had genuine pharmacological properties. Preparations containing henbane, which belongs to the nightshade family and contains compounds with sedative and analgesic properties, were used in medieval medicine as a kind of rudimentary general sedative. Mandrake root, another plant with a long and somewhat dramatic history in European folk medicine and pharmacology, was similarly employed and had the added advantage of an extensive mythological backstory that made it feel appropriately powerful. Preparations involving poppy, the opium poppy was known in medieval Europe, though the full development of opium-based pain management was more characteristic of the early modern period, could provide genuine analgesia. The challenge with all of these substances was dosage. Medieval pharmacology had no precise way of standardizing the concentration of active compounds in herbal preparations, so you might get a preparation that was mildly effective or one that was dramatically more potent than intended, with results that varied accordingly. Clove oil deserves a specific mention here. The use of cloves against dental pain is one of those medieval remedies that has actually survived into modern dental practice in modified form. Cloves contain eugenol, which is a naturally occurring compound with genuine analgesic and antibacterial properties, and applying clove oil directly to a painful tooth or gum provides real, measurable topical pain relief. When you recall that earlier you pressed cloves into your aching tooth and got some relief, that was not superstition working its psychological magic. That was actual pharmacological activity. Medieval people had, through long empirical observation, identified something that genuinely worked, even though they could not have told you why in any terms that would have made sense to a modern chemist. Now you are sitting on the barber surgeon's bench. He has looked at your tooth, probed it with a thin metal instrument in a way that has made your eyes water significantly, and has confirmed what you already suspected. It needs to come out. He has given you something to drink. You have decided not to ask exactly what it was, and you are now in that slightly dissociated state that suggests it contained at least some of the more potent herbs in his collection. He has selected his instrument. He is positioning himself in relation to your jaw with the focused calm of someone who has done this many times before, which is the single most reassuring thing about the entire situation. He is going to grip the bench or chair with one hand while working with the other, or alternatively he is going to stabilize your head somehow, because one of the practical challenges of tooth extraction without proper patient positioning equipment is that the patient tends to move, which makes the work harder and the outcomes less predictable. In some depictions of medieval tooth extraction, the practitioner stands behind or beside the patient with a knee or an elbow bracing the head, which gives the whole enterprise a quality of determined wrestling that is only slightly exaggerated. You are going to try very hard to hold still. You are not entirely confident you will succeed. The mainstream historical record here offers us something fascinating. The Worshipful Company of Barbers, established in London in 1308, represents one of the earliest formal professional organizations for what we might loosely call dental practice in the English-speaking world. This is a real institution that still exists today in a ceremonial form, a direct, unbroken thread connecting the medieval barber surgeon to the modern world, which is the kind of historical continuity that becomes quietly astonishing when you actually stop and think about it. 800 years of organizational memory, stretching from a man with a pelican and an alarming apron to, well, whatever the modern equivalent is, which involves considerably more sterilization and considerably less public spectatorship. A quirky detail that is genuinely worth tucking away: there is evidence from medieval sources that some practitioners offered a kind of guarantee on their tooth extractions, not in any legally enforceable sense, but in the practical sense that if the extraction went wrong, if the crown broke off, if the wrong tooth came out, if the patient was left in worse condition than before, there were understood social and reputational consequences. The marketplace of medieval medical practice was small enough, and word of mouth powerful enough, that a practitioner who routinely botched procedures would find their customer base drying up with some efficiency. This created a rough form of accountability that operated entirely outside any formal regulatory system, driven purely by community knowledge and reputation. It is not modern professional licensing, but it is not nothing either. The barber surgeon is ready. You are as ready as you are going to be. Take a breath. Hold it. Let the herbal preparation do whatever it is going to do. And understand, in the warm, detached way that you understand things when you are lying comfortably in the dark rather than actually in a medieval marketplace, that you are about to experience one of the most universal human experiences in history, shared by everyone from the poorest peasant in an English village to the most powerful monarch in a European palace. Everyone in the medieval world eventually lost teeth. The king and the beggar, the abbess and the fishwife, the scholar and the soldier. The mouth was the great equalizer, in its way, and what happened in it was something everyone understood from personal experience. There is something strangely democratic about that, something humanizing about the knowledge that the person on the throne had the same wincing relationship with their back molars that you have had at your worst dental moments. The instrument is positioned now. The barber surgeon has one hand braced, the other wrapped around the handle of the pelican with the practiced confidence of long experience. He says something to you, encouragement, instruction, possibly a quick prayer, because even practitioners worked in a world where the divine and the practical were not cleanly separated, and then he begins. The world narrows to that one point of pressure in your jaw. Everything else, the sounds of the market outside, the smell of the workshop, the texture of the bench beneath your hands, recedes. There is only the pressure and the building resistance, and then the sudden surrender of something that was never meant to move but is moving now, and then, following swiftly behind it like the release after a long-held breath, a rush of feeling that is not quite pain and not quite relief but something in between, something purely and entirely physical, a sensation so direct and unmediated that it briefly empties your mind of everything else. And then it is over, or at least this part is over. The tooth is out. You can feel the space where it was, which is bleeding freely and tastes of iron and salt. The barber surgeon is doing something with a cloth, applying pressure, speaking with the brisk efficiency of someone moving on to the next task, giving you instructions about what to eat and what to avoid and possibly what to apply to the socket. The pain is still there, but changed. Less that maddening deep throb and more a sharp, clean ache that already feels like it is beginning to belong to the past rather than the present. You have survived your medieval tooth extraction. So did most people eventually, more or less. The barber surgeon is already turning toward his next patient. Outside, the market goes on. Rest now in the aftermath of that imagined experience, and let your own jaw unclench, because you have been holding it tight for the last several minutes, and it is time to let it relax. The barber surgeon was not gentle, but he was skilled, and he did what he could with what he had, and in the context of his time and place, that was not nothing. It was, in fact, quite a lot. The cloves helped, but they were not enough. You know this now, sitting in the aftermath of your extraction with a piece of cloth pressed against the socket and the iron taste of blood at the back of your throat. But the cloves had given you a few days of partial relief before things got bad enough to visit the barber surgeon. And in that period of managing rather than solving, you had moved through a remarkable pharmacopoeia of remedies that most of your neighbors had opinions about and almost everyone had tried at some point. Medieval people did not simply sit with pain and wait for the professional to arrive. They experimented, they consulted, they combined, they layered remedy upon remedy with the dedicated resourcefulness of people who understood that waiting was its own kind of risk. The world of medieval dental remedies is one of the most genuinely fascinating corners of medical history, and not purely because some of the treatments are spectacularly strange, though they are. It is fascinating because it represents a kind of living laboratory that ran continuously for centuries, driven by real pain and real need, and that produced, amid considerable noise, some genuine signals. Some medieval remedies for toothache were entirely ineffective by any pharmacological measure, operating entirely through psychological mechanisms or simply not operating at all. Some were mildly effective. Some were genuinely effective, for reasons their practitioners could not have articulated in modern terms but understood empirically through observation and repetition. And some were actively harmful in ways that added new problems to the original one, which is a pattern that turns out to be remarkably common in the history of medicine generally, not just the medieval chapter of it. Let us begin with the plants, because the plant-based remedies represent the most substantial and interesting portion of the medieval dental pharmacopoeia, and because they connect, in ways that are still being traced and argued about by researchers, to the modern pharmaceutical tradition in more ways than most people realize. Cloves, as established, were genuinely useful. Eugenol, the active compound, is still used in dentistry today, usually in a more refined and standardized form, as a topical analgesic and antiseptic. But cloves were expensive in medieval Europe. They came from the Spice Islands in what is now Indonesia, traveled along trade routes that spanned half the world, and arrived in European markets as a luxury product that cost real money and was not available to everyone at all times. The fact that medieval people identified cloves as specifically useful for dental pain despite their expense tells you something about how seriously they took tooth pain as a problem worth investing resources in solving. For people who could not afford or could not access cloves, there were local alternatives. Henbane was widely used, applied either as a fumigation, burning the seeds and directing the smoke into the mouth, which gets the active compounds into the mucous membranes through inhalation, or as a direct topical application of various preparations made from the plant. Henbane contains hyoscyamine and scopolamine, which are compounds with genuine anticholinergic properties that can produce sedation and reduce pain sensitivity. The fumigation method is particularly interesting because it represents a delivery mechanism that actually works reasonably well for getting pharmacologically active compounds to the target area, even though the medieval practitioners who developed it were working entirely from observed effect rather than any understanding of the underlying chemistry. Pellitory of Spain, a plant in the daisy family whose roots have a strong, almost numbing quality when chewed, was another common dental remedy, and this one also has a genuine pharmacological basis. The active compounds in pellitory root produce a distinctive tingling and then numbing sensation when applied to the gum tissue, and it was widely recognized in medieval herbal traditions across Europe as specifically useful for tooth and gum pain. You can still find pellitory referenced in herbal medicine traditions today, which is a modest but real form of pharmaceutical continuity stretching back through the medieval period to ancient sources. Willow bark deserves mention here even though its primary association is with general pain relief rather than specifically dental pain, because it represents one of the clearest examples of medieval herbal practice identifying something that genuinely works. Willow bark contains salicin, which the body metabolizes into salicylic acid, which is chemically related to aspirin. Medieval people used willow bark preparations for pain, fever, and inflammation, the classic triad of conditions that aspirin addresses, and while their understanding of why it worked was entirely wrong by modern standards, their identification that it did work was entirely correct. When your medieval neighbor told you to chew some willow bark to help with the pain in your jaw, they were giving you advice that was pharmacologically sound, delivered within a theoretical framework that was entirely mistaken but an empirical framework that was solid. Now we arrive at the section of the medieval dental remedy tradition that requires a slightly different register, because we are moving from the pharmacologically interesting into territory that is going to take a moment to fully absorb. These are the remedies that did not work or that worked only through psychological mechanisms, or that were based on theories about how the body and the world functioned that have no correspondence to physical reality as we currently understand it. They are presented here with full respect for the ingenuity and genuine intent of the people who devised and deployed them, and with the understanding that from within the worldview that produced them, they made complete and coherent sense. Ratskulz. Let us just address this directly. Several medieval sources recommend the application of a dead mouse or rat, or specific parts thereof, to a painful tooth or jaw as a remedy for toothache. The theories behind this recommendation varied. Some sources suggest that the animal's spirit or vital essence transfers to the affected area. Others that the specific properties of rat bones had a direct therapeutic effect. But the core recommendation appears in enough independent sources across enough different medieval medical traditions that it cannot be dismissed as a single eccentric outlier. People tried this. Some of them probably reported that it helped because pain is variable and the placebo effect is real, and sometimes a toothache just eases on its own and whatever you most recently tried gets the credit. The use of sympathetic magic in dental remedies is a broader category that the rat skull fits into, and it is worth understanding the logic of sympathetic magic before dismissing it, because the internal coherence of the system is genuinely interesting. Sympathetic magic operates on the principle that like affects like, and that things which resemble each other or have been in contact with each other retain a connection that can be exploited for therapeutic purposes. Applied to dental pain, this produced recommendations like wrapping a tooth that had been extracted around a nail and hammering the nail into a tree, on the theory that the pain would transfer into the tree and you would be relieved of it. It produced recommendations for writing specific words or numbers on paper and consuming or wearing them. It produced an entire genre of dental amulets, objects to be worn or carried that would protect the wearer against toothache, that varied by region and tradition but shared the basic structural logic of the protective charm. Here is the quirky historical tidbit that deserves its own moment. There are records from medieval and early modern England of a practice involving touching a dead man's tooth, specifically a tooth taken from a person who had died of a non-dental cause, to a painful living tooth, on the theory that the dead tooth would somehow absorb or neutralize the pain from the living one. This is operating somewhere at the intersection of sympathetic magic and early folk pharmacology, and while it is entirely ineffective by any modern measure, it is also connected, in a strange genealogical way, to the later practice of tooth transplantation, which we will discuss at length in a later section and which turns out to have its own deeply uncomfortable history. The verbal and textual remedies, the charms, the prayers, the specific words written or spoken as part of the treatment, form another major category of medieval dental intervention, and they are worth taking seriously as historical phenomena even if they are not serious as medical interventions. The charm tradition in medieval dental care is extensive and geographically widespread. There are charms recorded in Anglo-Saxon medical manuscripts, in continental European herbals, in ecclesiastical texts that included them with apparent unease about their relationship to Orthodox Christian prayer, and in folk collections that were still being recorded in rural communities well into the 19th and 20th centuries. A typical dental charm might involve reciting a specific verse, often in Latin or in a mix of Latin and the vernacular, while performing a physical action with the tooth or the affected jaw. The verses often referenced biblical or hagiographic narratives, the story of Christ healing the sick, the specific martyrdom story of Saint Apollonia, episodes from the lives of other healing saints, and the logic was that invoking the sacred narrative in close association with the physical ailment would produce a transfer of healing power from the sacred realm to the suffering body. From within medieval Catholic theology, this was not entirely illogical. The saints were understood as active intercessors who could and did intervene in physical suffering, and addressing them with specific, formulaic invocations was simply the appropriate procedure for accessing that intercession. Historians still argue whether the charm tradition in medieval medicine should be understood primarily as a religious phenomenon, a magical phenomenon, or something that does not map cleanly onto either modern category. The distinction between approved religious practice and disapproved magical practice in medieval Christianity was real but contested, and the boundaries shifted depending on time, place, ecclesiastical authority, and the specific form of the practice in question. A prayer to Saint Apollonia was unambiguously legitimate. A charm involving specific numbers, physical objects, and actions that looked more like ritual manipulation than petition might attract suspicion. But in practice, ordinary people moving through their daily experience of pain and uncertainty often did not observe these distinctions with great care, deploying whatever combination of prayer, charm, herbal remedy, and physical intervention seemed most likely to help. The fumigation method deserves extended attention because it represents a particularly interesting technology in the medieval dental toolkit. The basic procedure involved burning specific materials and directing the resulting smoke toward the painful area of the mouth, either by leaning over the smoke, or using a tube of some kind to channel it, or constructing a small tent arrangement over the patient's head. Henbane seeds were the most commonly recommended material for dental fumigation, but other substances appear in various sources. Dried herbs, resins, combinations of plant materials that together created a complex smoke with multiple potentially active compounds. The fumigation method is interesting because it was genuinely clever as a delivery mechanism. Getting pharmacologically active compounds into the mucous membranes of the mouth and nose through inhalation is actually more efficient in some ways than topical application. And the people who developed this technique arrived at it through pure empirical observation with no understanding of the pharmacological principles involved. The dietary remedies for dental pain form yet another category. Various foods and drinks were recommended not just for their direct pharmacological effects, but for their supposed relationship to the underlying causes of dental pain as medieval medicine understood them. Hot food and drink were sometimes recommended to drive out cold humors thought to be causing pain. Cold substances were sometimes recommended to reduce heat and inflammation. Rinsing the mouth with wine was a genuinely useful antiseptic intervention, since wine's alcohol content and acidity create a mildly hostile environment for certain oral bacteria, even if the medieval practitioners recommending it understood its mechanism entirely differently. Rinsing with warm salted water, another common recommendation, is also genuinely somewhat useful for gum inflammation, which is a nice example of empirical observation arriving at a practically sound recommendation through completely incorrect reasoning. There was also a substantial tradition of dietary advice aimed at preventing dental problems rather than treating them, and this is where the medieval medical tradition shows some of its most interesting moments of near-miss insight. Various medieval health guides, the genre of text called the Regimen Sanitatis, which were essentially lifestyle management manuals for the maintenance of health, included advice about teeth that ranged from the genuinely sound to the thoroughly mistaken. Advice to avoid very hot and very cold foods in rapid succession, on the grounds that the sudden temperature changes damage the teeth, has a real basis in the thermal stress effects on dental enamel. Advice to rinse the mouth after eating, on the grounds that food residue remaining in contact with the teeth caused them to decay, is also pharmacologically sound even if the mechanism was described in humoral rather than bacteriological terms. What is striking about all of this, when you step back and take the full view, is that the medieval dental remedy tradition was not a random collection of superstitions. It was a system imperfect, theoretically mistaken at its foundations, with a signal-to-noise ratio that modern evidence-based medicine would find deeply unsatisfying, but a system nonetheless. It was organized around coherent principles, even if those principles were wrong. It was refined through observation and transmitted through established channels. It represented the best available attempt to address a real and universal human problem with the intellectual and material resources available. You are lying in your imagined medieval cottage now, in the early afternoon following your extraction, with a cloth packed against the socket and a small cup of something warm and herbal, wine with something added, you think, something slightly bitter, that the barber surgeon pressed into your hands as you left. The worst is over, or at least the acute worst. The socket aches with the clean ache of a thing newly done rather than the poison throb of the infection, which is already beginning to ease slightly now that the infected tooth is gone. Someone from the village has brought you a preparation of something. Herbs you do not fully recognize, a paste that smells strongly of something resinous and sharp, and told you to press it gently against the socket to help it heal. You do not know if it will help. They say it does. You have decided to believe them, because believing them costs nothing and might offer something. This is how most of medieval medicine worked, really. Not in grand theoretical frameworks, but in small, local, accumulated exchanges of practical knowledge between people who were all trying to navigate the same difficult terrain. The woman who brought you that herbal paste learned it from her mother, who learned it from hers, in a chain of transmission that stretched back into an oral tradition too old and too distributed to have a single identifiable origin. Whether it helped in any pharmacological sense mattered less than the fact that it represented care. Someone noticing your pain and responding to it with the best thing they had to offer. That impulse, that responsiveness to another person's suffering with whatever tools are available, is the thread that connects the rat skull and the clove and the henbane fumigation and the prayer to Saint Apollonia and the warm wine rinse. They are all expressions of the same fundamental thing: the refusal to leave someone alone with their pain. Sink into that thought for a moment as you drift. The remedies were imperfect. The theories were wrong. But the care was real. The herbal paste is doing its quiet work against your socket, and the afternoon light is thinning toward evening, and somewhere in the back of your slowly relaxing mind a question is forming that you have not quite articulated yet. Why exactly were there so many toothaches to treat? Why was dental decay so pervasive, so universal, so thoroughly woven into the fabric of medieval daily life that an entire ecosystem of remedies, practitioners, prayers, and professional organizations had grown up around it? The folk knowledge existed because the need was constant. The barber surgeon had steady work because the patients kept coming. Saint Apollonia had devoted followers because toothache was something everyone either had or expected to have. a condition as reliably present as cold winters and muddy roads. The answer to why medieval teeth were in such consistent trouble is not simple, and it is not the answer you might expect. It involves sugar, certainly, but sugar in a more complicated and historically specific way than the straightforward narrative of medieval people eating too many sweets would suggest. It involves grain and the particular chemistry of cooked carbohydrates and their interaction with the bacteria that live in the human mouth. It involves fasting, which is a religious practice you might not immediately associate with dental decay, but which turns out to have a surprisingly direct relationship with it. And it involves the profound differences between what different people ate depending on their social position, their religious obligations, their geographic location, and the season of the year, differences that produced genuinely different dental outcomes across medieval society in ways that researchers are still working to fully map. Let us begin with the grain, because grain is the foundation. The medieval diet for the vast majority of the population was built around bread and porridge and other grain-based foods in a way that is difficult to fully appreciate from a modern vantage point, where carbohydrates are just one category among many in a varied diet. For a medieval peasant, grain was not a component of the diet. It was the diet, supplemented by vegetables, legumes, dairy products when available, and meat on occasions that varied from relatively frequent to vanishingly rare depending on circumstances. Bread in particular was understood not as a side dish or an accompaniment, but as the central, defining food, the thing around which everything else organized itself, the substance that stood between you and hunger in the most fundamental sense. Now, the specific relationship between grain-based diets and dental decay is something that archaeologists and dental researchers have been studying carefully, and what they have found is interesting and slightly counterintuitive. Raw grain, like the teeth of hunter-gatherers who ate a diet high in meat and foraged plant foods and relatively low in processed carbohydrates, tends to produce significant tooth wear but relatively low rates of dental caries. The grinding and chewing required to process raw or minimally processed foods is hard on enamel surfaces, producing the characteristic wear patterns visible in pre-agricultural human skulls. But the specific chemistry of caries, which requires fermentable carbohydrates to feed the bacteria that produce the acids that dissolve tooth enamel, is less favorable in a diet dominated by fibrous, unprocessed foods. Cooked and processed grain is a different matter. Bread, porridge, pottage, the various grain-based preparations that formed the backbone of the medieval diet. These are full of fermentable carbohydrates in forms that oral bacteria find extremely hospitable. The shift to agriculture and grain-based diets that occurred in the Neolithic period produced a measurable increase in dental caries rates in human populations, and the medieval period, with its extraordinarily grain-heavy dietary patterns for the majority of the population, represents a continuation and intensification of this dietary pattern. When you eat bread, the carbohydrates cling to your tooth surfaces and feed the bacterial communities in your mouth, which produce acids that attack your enamel. And if you are eating bread multiple times a day because it is your primary caloric source, those bacterial communities are essentially being continuously supplied with their preferred fuel. This is the backdrop against which everything else in the medieval dental picture needs to be understood. The grain baseline already created favorable conditions for decay. Everything else, sugar, honey, dried fruits, the specific patterns of fasting and feasting, operated against this backdrop, sometimes intensifying it and sometimes in interesting ways moderating it. Sugar, now. Sugar in the medieval period is a completely different substance, socially, economically, symbolically, from what it is in your refrigerator. Refined cane sugar first became available in Europe through Arab trade routes beginning in the early medieval period, and for most of the Middle Ages it remained a luxury product of extraordinary value, available only to the wealthy, used in small quantities as a spice or a medicine rather than as a bulk sweetener. Medieval medical tradition, drawing on Arabic medical sources, actually classified sugar as a medicinal substance and recommended it for a range of conditions. It was considered warming and moistening in the humoral framework, and was prescribed for coughs, digestive problems, and various other ailments. The idea that sugar might be harmful to teeth was not part of the medieval medical understanding of the substance. On the contrary, it was medicine, and you did not worry about the side effects of medicine the way you worried about the side effects of, say, excessive henbane fumigation. The wealthy, therefore, consumed sugar in ways that were understood as healthful and sophisticated rather than indulgent and dangerous. Sugar sculptures, elaborate decorative centerpieces made entirely from sugar, called sodal teas, which graced the tables of the aristocracy at important feasts, were both a display of wealth and a form of conspicuous pharmaceutical consumption. Spiced sugar mixtures were served at the end of meals as digestive aids. Sweetened wines and confections were markers of social status. And the teeth of the wealthy, paradoxically, often suffered more from caries than the teeth of the poor, precisely because sugar was the province of people who could afford it. Archaeological evidence from medieval aristocratic burials frequently shows higher rates of certain types of dental decay than equivalent evidence from poorer populations. A reversal of the modern pattern where poverty is associated with worse dental health, and one that reflects the specific economics of sugar access in the pre-industrial world. Queen Elizabeth I of England, who sits just at the edge of the medieval and early modern boundary, is the famous exemplar of this phenomenon. Her teeth were reportedly blackened by sugar consumption, and black teeth became briefly fashionable among the English elite as a signifier of the wealth required to eat enough sugar to produce that effect. This is the kind of historical detail that sounds like it was invented for the purpose of making a point but is actually entirely documented, and it encapsulates perfectly the paradox of medieval and early modern sugar. The thing that was destroying teeth was simultaneously a luxury, a medicine, and a status symbol, and nobody in the world that produced this situation had any framework for connecting those dots. Honey occupied a related but distinct position in the medieval sweet landscape. Honey was the primary sweetener available to the majority of the population. Sugar was for the rich, but honey was produced locally and was accessible at various levels of the social hierarchy. Medieval honey consumption was substantial and embedded in daily practice in ways that extended well beyond simple sweetening. Honey was used in cooking, in brewing. Mead was a genuine staple beverage in early medieval Europe before hop-based Alesh became dominant, in medicine, and in food preservation. The dental implications of honey consumption were understood no better than those of sugar, and honey's high sugar content, combined with its viscous texture that allowed it to cling to tooth surfaces for extended periods, made it effectively comparable to refined sugar in terms of its cariogenic properties, even if medieval people would have been baffled by the idea that medicine could be causing tooth decay. Now here is where the fasting comes in, and this is the part that tends to genuinely surprise people. The medieval Catholic Church prescribed an extensive calendar of fasting periods, Lent being the most famous and most demanding, but joined by numerous other fast days throughout the year, the Ember Days, the vigils of major feasts, Fridays in general, and various other occasions depending on local tradition and individual piety. In total, a devout medieval Christian might observe something approaching a third of the year as some form of fast or restricted diet day. The nature of the fasting varied. The most demanding fasts restricted not just certain foods but the timing and quantity of eating generally, while less rigorous versions simply prohibited meat and sometimes dairy and eggs, pushing the fasting person toward a diet of fish, vegetables, legumes, and grain-based foods. The dental implications of this fasting calendar are surprising and somewhat ironic. Periods of fasting, particularly the more demanding ones, reduced overall caloric intake and changed the frequency of eating, which in theory might be expected to give the oral bacterial environment less fuel and perhaps slow the progress of decay. But the specific foods that were permitted during fasting periods, fish certainly, but also the preserved fish that featured heavily in the medieval Lenten diet, heavily salted, sometimes dried, sometimes pickled, had their own complex relationships with dental health. More significantly, the feasting that followed fasting periods tended to be intensive and prolonged, with the accumulated restrictions of Lent giving way to Easter celebrations that involved substantial quantities of exactly the foods that had been prohibited, including meat, eggs, dairy, and honey-sweetened preparations. The feast and fast rhythm of the medieval liturgical calendar thus created a pattern of dietary variation that had complicated and not entirely predictable effects on dental health. Historians still argue whether the net effect of the fasting calendar on medieval dental health was positive, negative, or neutral. The answer probably varied significantly by individual, by region, by social class, and by the specific foods available during fasting periods in different parts of Europe. What is clear is that the fasting calendar was not primarily designed with dental health in mind, that its designers had no framework for thinking about it in those terms, and that its effects on teeth were an unintended consequence of a religious practice organized around entirely different concerns. The specific foods permitted during Lent and other fasting periods also tell an interesting story about the geography of medieval dental health. In coastal regions where fresh and preserved fish were abundant, the Lenten diet had a relatively high protein content and a lower carbohydrate proportion than the everyday grain-heavy diet of inland agricultural communities, which might have offered some dental protection. In inland areas where fish was expensive or unavailable, fasting periods often pushed people toward a diet that was even more heavily dependent on legumes and grain preparations than their ordinary diet, which from a dental perspective was not necessarily an improvement. The seasonal dimension of medieval diet also matters here and is often underappreciated. Medieval food supply was not the year-round abundance that modern food systems provide. It was deeply seasonal, with periods of relative plenty following harvest and periods of genuine shortage in late winter and early spring before the new growing season got underway. Malnutrition, even relatively mild seasonal malnutrition, can impair the immune system's ability to manage oral infections, can affect the development of enamel in children, and can interact with existing dental disease in ways that accelerate its progression. Children's dental health deserves specific attention here. The period of enamel formation, during which the permanent teeth are developing within the jaw before they erupt, is a critical window during which nutritional adequacy significantly affects the quality of the resulting enamel. Children who experience periods of nutritional stress, illness, or other physiological disruption during this developmental window may develop enamel that is structurally weaker and more susceptible to decay than well-nourished children. Archaeological evidence from medieval child burials shows these developmental disruptions recorded in the enamel of the permanent teeth as distinctive lines or bands, called enamel hypoplasia, that are essentially a diary of physiological stress written into the tooth itself. When researchers examine medieval child skulls, they can often read the history of difficult winters or serious illnesses in these enamel records, and they can see how children who experienced multiple episodes of stress were set up for dental difficulties even before their adult teeth had fully erupted. The interaction between the church, diet, and dental health extended beyond the fasting calendar into the specific foods that church institutions produced and distributed. Monasteries were major producers of honey throughout the medieval period, maintaining apiaries not only for their own needs but as a source of income and charitable distribution. Monastic breweries produced ale and other fermented drinks that were distributed to the poor and consumed in quantity by the monks themselves. Monastic bakeries produced bread not just for internal consumption but for charitable distribution. In each case, the church was functioning as a major distributor of the foods most associated with dental decay, entirely without awareness of this dimension of its charitable activities. The picture that emerges from all of this is not a simple one. Medieval dental decay was not the result of ignorance or negligence alone. It was the product of a complex interaction between diet and poverty and agricultural practice and religious culture and trade economics and the specific biochemistry of oral bacteria. It was, in a real sense, the dental expression of an entire civilization's choices and constraints, a record written in enamel and bone of what people ate and how they lived and what they valued and what they could not afford to know. You are thinking about all of this now in your imagined afternoon, lying still while your socket settles into its new emptiness. You have eaten nothing since the morning, following the barber surgeon's instructions, and you are aware of a specific kind of hunger that the cloth in your mouth does nothing to address. Later, you will be permitted to eat soft things, pottage, something without much texture, food that will not disturb the socket. Grain-based, of course, always grain-based. The diet that helped put you in this position is also the diet you will use to recover from it, because it is the diet you have, the diet your world produces, the diet your social position provides. There are no other options. This is the specific texture of medieval constraint. Not a lack of intelligence or care, but a set of circumstances so thoroughly surrounding a person on all sides that the idea of stepping outside them was simply not available. You ate what your world grew. Your world grew grain. Your teeth paid the price. And the extraordinary thing, the thing worth carrying quietly into sleep, is that the people who lived this way found it neither extraordinary nor particularly unfair. It was simply life. It was the weather of existence. You dealt with it as you dealt with all weather, with the tools you had, and the help of your neighbors, and the faith that tomorrow would be navigable even if today was difficult. The evening is coming down around the village now, soft and gray, and someone has lit a fire in the hearth and the smell of wood smoke is threading through the air like a kind of punctuation, marking the shift from day to something slower and more interior. Your jaw aches. The pottage will be ready soon. The fire is warm. That is enough for this moment, and it was enough then too. The pottage was enough for you, there in your small village with your freshly emptied socket and your wood smoke evening. But across the medieval world, in the great stone halls and curtained chambers of the aristocracy, in the royal palaces where tapestries kept out the draughts and spiced wine came in silver cups, a very different relationship with food was being enacted every day, and it was producing dental consequences that were, in their own way, just as dramatic as anything happening in the poorest agricultural community in England or France or the Holy Roman Empire. The story of royal and noble teeth in the medieval period is one of the more quietly satisfying ironies in all of medical history, and it deserves to be told with the full appreciation its paradoxes have earned. Wealth, in the medieval context, did not protect your teeth. In many cases, it actively destroyed them, and it did so through mechanisms that were entirely invisible to the people experiencing the destruction, because the foods that were rotting royal teeth were simultaneously the foods that defined royal status, royal pleasure, royal medical care, and royal social performance. To eat richly in the medieval period was to eat sweetly, and to eat sweetly was to eat in ways that oral bacteria found absolutely delightful, and the result was a pattern of dental disease among the elite that archaeological evidence has confirmed with some consistency across multiple royal and aristocratic burial sites in Europe. Let us spend some time with a few specific individuals, because the abstract pattern becomes considerably more vivid when you can attach it to actual people with actual documented dental histories. We will move carefully here, staying with what the physical and historical evidence actually supports rather than embroidering too freely. But the evidence is rich enough that embroidery is largely unnecessary. Henry VIII of England, who again sits at the medieval and early modern boundary but whose diet and medical history are extensively documented, is perhaps the most famous example of the wealthy teeth decay paradox. His accounts show extraordinary quantities of sugar consumed in his household, sugar used in cooking, in confections, in medicines, in the elaborate subtleties that decorated his feasts. His dental health was, by the accounts of those who had occasion to be near him in his later years, genuinely terrible, contributing to the breath problems that his courtiers apparently found challenging to diplomatically ignore. His case is well documented enough to be instructive, but he is representing a pattern rather than an exception. Going further back into the specifically medieval period, the physical examination of royal remains has produced some striking evidence. The skeleton of Richard III of England, discovered beneath a Leicester car park in 2012 in one of the more remarkable archaeological finds of recent decades, was subjected to extensive analysis that included examination of his dental health. The findings showed evidence of dental decay consistent with a high-sugar diet, which aligns with what the historical record tells us about aristocratic eating patterns in 15th century England. Richard was not unusual in this. He was typical of his class, eating in the ways that his class ate, and his teeth reflected that diet with faithful accuracy. The contrast with peasant dental health is real, but also complicated in ways that the simple rich versus poor narrative does not fully capture. Peasant teeth, as established, suffered significantly from the effects of coarse grain-based diets and limited access to dental care. But the specific pattern of decay differed from the aristocratic pattern in ways that are diagnostically interesting. Peasant dental wear, the physical grinding down of tooth surfaces from a lifetime of chewing coarse, gritty bread and other rough foods, was often dramatic, with elderly individuals sometimes showing teeth worn almost to the gum line. Caries patterns in peasant populations tended to appear more on the surfaces between teeth and at the gum line, reflecting the specific way that coarse dietary fiber interacted with tooth surfaces. Aristocratic caries patterns showed more pit and fissure decay, the specific pattern associated with fermentable carbohydrates pooling in the small grooves and pits of molar surfaces, which is the caries signature of a diet high in refined sugars and soft, sticky sweet preparations. So your village neighbor with the worn-down teeth and the extraction scars was experiencing different dental disease than the baron in his hall with the blackened molars and the sugar-rotted incisors, but both of them were experiencing dental disease, and neither of them had effective treatment. The gap in access to care was real and significant. The baron could afford to send for whatever practitioner was available, could afford the more expensive remedies and the more skilled barber surgeons, could have instruments of higher quality applied to his teeth by practitioners who had more experience with wealthy patients. But none of this closed the fundamental gap between what was needed and what was available, because what was needed did not exist yet. Royal courts had court physicians, and court physicians had opinions about teeth. The medical advice available to medieval monarchs was, by the standards of the time, the most sophisticated available, drawing on university-trained doctors who had read the full available corpus of classical and Arabic medical literature, and who could bring that theoretical framework to bear on whatever problem they were addressing. In practice, this meant that a medieval king with a toothache had access to the most learned available interpretation of what was wrong with him and why, and that interpretation was still largely organized around humoral theory and still largely disconnected from any effective intervention. Court physicians could recommend dietary modifications. They could prescribe specific herbal preparations of higher quality and greater refinement than a village healer might have access to. They could draw on a wider pharmacopoeia, including expensive imported substances like theriac, a legendary compound preparation that was essentially the medieval equivalent of a cure-all, containing dozens of ingredients and costing extraordinary sums, and various aromatic preparations involving substances from the spice trade. They could offer learned opinions on the spiritual and constitutional dimensions of the royal patient's dental problems. What they could not do was fix a decaying tooth in any fundamental way, because fixing a decaying tooth required either effective prevention, which medieval medicine could not provide, or effective extraction and replacement, which medieval medicine could provide in only the most limited and imperfect sense. The dental histories of medieval royalty are interesting not just as individual stories but as evidence of how the intersection between wealth, status, and medical care actually functioned in practice. A monarch who was suffering from serious dental disease created a specific kind of political problem, because the health of the king or queen was understood in medieval political theology as intimately connected to the health of the realm. A visibly suffering, pain-distracted, or physically incapacitated monarch was not just a medical patient but a symbolic problem, and the court's management of royal dental disease often reflected this political dimension as much as any medical one. There are records of monarchs conducting public business while clearly suffering from dental pain, audiences granted, documents signed, diplomatic negotiations conducted through the particular fog of a serious toothache, with courtiers carefully not noticing that their sovereign was pressing a hand to their jaw at intervals or occasionally going somewhat pale. There are also records of the opposite. Monarchs so incapacitated by dental pain and its complications that state business ground to a halt or had to be managed by deputies. Dental abscesses in particular could produce the kind of systemic illness, fever, swelling, difficulty swallowing, genuine toxicity from spreading infection, that rendered a person largely non-functional for days or weeks. The noble women of medieval courts present a somewhat different picture that is worth separating out briefly, because the specific pressures on aristocratic women's dental health added dimensions that their male counterparts did not face in the same way. The physiological demands of pregnancy and lactation that we touched on earlier were more directly present in the lives of noble women, many of whom married young and spent significant portions of their adult lives pregnant or nursing. The calcium demands of multiple pregnancies, combined with a diet that, while rich in calories and sugar, was not necessarily better supplied with the specific micronutrients needed for optimal dental health, created conditions that could accelerate dental deterioration even against the background of general aristocratic wealth. The social pressure on aristocratic and royal women to maintain a pleasing appearance added another dimension. Tooth loss in a noblewoman was not just a health problem or a comfort problem. It was a social and political problem, affecting her marriageability if she was unmarried, her social position if she was married, and her perceived vitality and desirability in a world where physical appearance was bound up with political and dynastic function in complex ways. The response to this pressure was, as we will discuss in a later section, an early and considerable investment in tooth replacement, in the artificial teeth, the dentures, the transplanted teeth from other mouths that represented medieval and early modern attempts to address the visible consequences of dental disease, even when the disease itself could not be effectively prevented or treated. The diet of the medieval aristocracy deserves a closer look at its specific composition, because the broad strokes of rich food and lots of sugar do not fully capture the complexity of what noble tables actually offered and how it affected teeth. Aristocratic feasts featured meat in quantities and varieties unavailable to most of the population. Roasted, stewed, in elaborate pies and pastries, prepared with spice mixtures that were themselves expensive and status-laden. The meat itself was not particularly karyogenic, but the preparations it appeared in often were meat pies with pastry crusts, heavily sweetened sauces, dishes combining meat with dried fruits and honey in the sweet-savory combinations that medieval aristocratic cuisine favored. The bread served at noble tables was whiter and finer than peasant bread, made from more finely milled flour, and while this might sound like an advantage, fine white bread produces more easily fermentable starch in the mouth than the coarser grain preparations of the peasant diet, and was thus in some ways worse for dental health despite being considerably more expensive. The wine that flowed freely at aristocratic tables had its own relationship with dental health. Wine is acidic, and chronic exposure to acidic beverages gradually erodes tooth enamel through a process called acid erosion, which is distinct from bacterial caries but produces its own forms of tooth damage and sensitivity. The wealthy drank more wine than the poor, who more commonly drank ale, and ale, being less acidic, was probably less erosive in this specific way. Medieval wine was also frequently sweetened or spiced with sugar and honey, adding karyogenic compounds to its already acidic baseline. Historians still argue about the net dental health differential between different social classes in medieval Europe, whether the specific advantages that wealth provided in terms of access to care and quality of remedies were sufficient to offset the specific disadvantages it created in terms of dietary karyogenicity. The answer probably varied by time period, region, specific individual, and the particular form that wealth took in a given context. What seems clear from the cumulative evidence is that dental disease was not something that money solved in the medieval period. It was something that money sometimes transformed, shifting the specific pattern of disease, changing the timing of certain dental events, altering the management experience, but not something that money prevented or cured. This is a leveling fact in its way. The peasant grinding his worn teeth on coarse bread and the king rotting his molars on sugar subtleties were both, in the end, navigating the same fundamental absence. The absence of anyone who could really fix what was wrong with their teeth. The social distance between them was vast, one of the vastest that human civilization has ever institutionalized. But in the dental chair or on the extraction bench, that distance collapsed into something like equality. Both of them hurt. Both of them lost teeth. Both of them faced the same empty socket afterward, and felt with their tongue the same strange new geography of absence. There is something worth holding on to there. Not a sentimental erasure of genuine and consequential social inequality, but a recognition that the body, in the end, does not observe class distinctions. It simply does what it does, and it does it to everyone, and the experience of navigating that reality connects people across centuries and social hierarchies in ways that the historical record only partially captures, but that the physical evidence, those skulls in their museum collections, those teeth with their caries and their wear and their extracted spaces, makes permanently, undeniably visible. The fire is lower now in your imagined hearth. The village has gone quiet with the specific quiet of a community that rises early and goes to bed accordingly, that does not have artificial light to extend the productive day beyond what darkness provides. Somewhere in a palace in a city you will never visit, a baron is pressing a gold-ringed hand to his jaw and wishing, with the democratic sincerity of genuine pain, that he felt better. He does not feel better. Neither do you entirely. But the socket is cleaner now than the infected tooth was, and tomorrow the pottage will be easier to eat, and the day after that it will be easier still, and that incremental improvement is the closest thing medieval dentistry could offer to a cure. It was not nothing. It moved in the right direction, which is all any of us can really ask of our available remedies. Rest now. The baron's fire is also lower. Even the richest hearths need tending eventually, and eventually everyone, in every castle and cottage across the medieval world, lets the fire go down and closes their eyes and gives themselves over to the dark. The baron's jaw aches in his palace, and your jaw aches in your cottage, and the barber surgeon's jaw probably aches too, because nobody in the medieval world is exempt from the fundamental indignity of having teeth. And all three of you are lying in the dark thinking some version of the same question. Not why in the philosophical sense, not the grand cosmic inquiry into the meaning of suffering, but the smaller, more immediate, more practical why that pain always generates in its wake. Why does this happen? What is actually causing this? What is going on inside a tooth that produces this specific quality of misery, and is there a way to understand it well enough to stop it? Medieval medicine had answers to these questions. The answers were wrong, in the sense that they do not correspond to what modern dental science understands to be happening inside a carious tooth, but they were answers organized and coherent and in some cases remarkably persistent, surviving in various forms from ancient sources through the medieval period and into the early modern era despite the absence of any mechanism by which they could be confirmed or verified. The medieval theoretical understanding of dental disease is one of the more fascinating examples of a wrong idea with extraordinary staying power, and the most famous of these wrong ideas, the toothworm, deserves its own extended examination, because it is simultaneously one of the strangest and one of the most widely documented beliefs in the entire history of medicine. The toothworm. The idea is exactly what it sounds like. That toothache and tooth decay were caused by a small worm living inside the tooth, eating its way through the dental tissue, creating the holes and the pain and the progressive destruction that characterize dental caries. This belief was not a medieval invention. It appears in ancient Sumerian medical texts dating to around 1800 BCE, making it one of the oldest documented medical theories of any kind, a belief so old that it predates most of what we think of as ancient history. It appears in ancient Egyptian medical papyri. It appears in Greek and Roman medical sources. It traveled through Arabic medicine into European medieval medicine, where it was thoroughly integrated into both learned medical discourse and popular understanding, and it persisted in various forms well into the 18th century in some parts of Europe and even longer in folk medical traditions in certain regions. The persistence of the toothworm belief across such an enormous span of time and such a wide geographic range is genuinely puzzling if you approach it purely as a question of intellectual history. How does a theory that is entirely wrong survive for 3,500 years? The answer involves several interacting factors that, when you lay them out, actually make the toothworm's longevity considerably less mysterious. First, the toothworm was unfalsifiable in any practical sense within the intellectual frameworks available to pre-modern medicine. You could not look inside a tooth with sufficient magnification to see what was actually there. Microscopy did not exist until the 17th century, and dental microscopy as a serious investigative tool came considerably later than that. If someone told you there was a worm in your tooth and you could not look inside your tooth to check, the theory was neither confirmable nor deniable through direct observation, which meant it could be maintained indefinitely against the background of the circumstantial evidence that supported it. And there was circumstantial evidence, or at least things that could be interpreted as circumstantial evidence. The progressive nature of dental caries, the way it hollows out a tooth over time, creating a cavity that expands inward, looks, if you are thinking in terms of biological agents, like something eating its way through the tooth from the inside. The occasional presence of actual small insects or larvae in severely decayed teeth of dead animals or preserved organic matter provided a kind of analogical support. Worms did eat through organic material, worms did hollow things out from within, and the results looked something like dental caries. The fact that the pain of toothache had a specific quality, that particular deep, rhythmic, almost writhing ache that the sufferer experienced as something happening inside the tooth, also supported the worm hypothesis in a phenomenological way. Pain that feels like something alive and active inside your tooth is pain that a toothworm theory describes rather well, even if the actual cause is entirely different. Second, the toothworm theory was associated with a treatment tradition that provided at least the appearance of confirmation. One of the most widely documented treatments for toothache associated with the toothworm belief involved fumigation, burning henbane seeds or other materials and directing the smoke toward the affected tooth, on the theory that the smoke would drive out or kill the worm. After this fumigation, practitioners and patients sometimes reported seeing small white thread-like objects in the water or saliva that collected during the procedure, which were identified as the expelled worms and taken as confirmation that the treatment had worked and the theory was correct. What these objects actually were is a matter of some interest. They were probably coagulated mucus or salivary proteins, possibly small fragments of the dental pulp tissue itself, or in some cases simply debris from the fumigation material. But to an observer working within the toothworm framework, they looked like exactly what the theory predicted they would look like, and this apparent confirmation reinforced both the belief and the treatment tradition that went with it. The quirky historical tidbit here is almost too good to be true, but it is entirely documented. There exists a medieval illustration, reproduced in various histories of dentistry, that depicts the toothworm in considerable anatomical detail, shown as a small serpentine creature with a distinctly unhappy expression, coiled within the interior of a molar. This illustration was produced with the same careful observational intent that medieval natural historians brought to drawings of other creatures, real and imagined, and it represents a genuine attempt at empirical documentation within a completely mistaken theoretical framework. The worm is shown with the earnest specificity of something the artist believed in, and that belief is so thoroughly embedded in the image that it becomes, across the distance of centuries, almost touching. Mainstream medieval dental theory operated within a broader framework that extended well beyond the toothworm, and it is worth understanding the full theoretical architecture before focusing too long on any single element of it. The humoral tradition, as applied to dental disease, understood tooth decay and toothache as products of humoral imbalance, typically an excess of phlegm, which was the cold and wet humor, or of corrupt and burning humors that accumulated in the jaw and head and attacked the tooth and its surrounding tissues. The specific quality of the pain, sharp or dull, burning or aching, constant or throbbing, was read as diagnostic evidence about which humor was involved and in what proportion, and treatment recommendations followed from this diagnostic interpretation. This is actually a fairly sophisticated diagnostic framework in structural terms. The specific quality of pain as diagnostic information is something that modern medicine also uses, even if the interpretive categories are entirely different. A patient today who tells their dentist that the pain is sharp and brief in response to cold is giving information that points toward a different diagnosis than a patient who reports a dull, constant ache. And the dentist uses that differentiation to guide their intervention. Medieval practitioners using humoral categories to differentiate between types of dental pain were doing something structurally similar, using pain characteristics as diagnostic information, even though the specific categories they were using were wrong. The location of dental disease within the medieval understanding of the body systems also had theoretical implications that shaped treatment approaches in interesting ways. The head was understood as the seat of one of the body's most important regulatory relationships, the site where the brain processed information and where various channels and passages connected the internal body to the external world. The mouth and the teeth within it occupied a position in this system that made dental disease not purely a local problem but potentially a systemic one, a sign that something in the broader bodily economy was out of balance. This framing, while wrong in its specifics, had the practical consequence of encouraging a holistic approach to dental health that considered diet, sleep, digestion, and general constitutional state as relevant factors, which is not entirely different from the modern understanding that systemic health conditions can affect oral health and vice versa. The Arabic medical tradition, which was the most sophisticated medical scholarship available to medieval European practitioners, had particularly detailed things to say about dental disease and its causes. Avicenna, the 11th century Persian physician whose canon of medicine became one of the foundational texts of medieval European medical education, devoted considerable attention to dental disease, organizing it into categories based on causation: decay caused by excess external moisture, decay caused by internal corruption, pain caused by heat, pain caused by cold, and prescribing specific treatments for each category. Avicenna's dental taxonomy was adopted, adapted, and transmitted through European medical education, becoming part of the standard theoretical framework within which learned practitioners approached dental problems throughout the later medieval period. What Avicenna and the Arabic medical tradition added to European dental theory was organizational rigor and a more extensive pharmacopoeia. The range of substances recommended for dental problems in Arabic-influenced medieval medicine was considerably wider than what was available in the pre-Arabic European tradition, including ingredients from the full span of the trade networks that Arabic merchants maintained, substances from India, from Persia, from the Far East, that arrived in European medicine through the channel of Arabic translation and transmission. Some of these substances had genuine pharmacological properties. Others were included because of their symbolic or astrological associations within the Arabic medical framework. The combination produced a dental pharmacopoeia of impressive breadth and highly variable effectiveness. The astrological dimension of medieval dental theory is another element that requires acknowledgement because it was genuinely present and influential rather than a marginal eccentricity. Medieval medicine operated within a cosmological framework in which the positions of the planets and stars influenced the human body through correspondences that were understood as physically real rather than merely metaphorical. Specific teeth were associated with specific planets in some medieval astrological medical systems, and both the timing of dental procedures and the selection of treatments were sometimes guided by astrological considerations. The idea of performing a tooth extraction when the moon was in a specific position, or avoiding certain dental interventions during astrologically inauspicious periods, appears in enough medieval medical texts to represent a genuine strand of practice rather than isolated speculation. This astrological dimension intersected with the toothworm belief in interesting ways. Some versions of the toothworm theory held that the worm was born at specific astrologically determined moments, or that its activity waxed and waned with lunar cycles in a way that accounted for the characteristic fluctuation of toothache pain. The moon's association with moisture and with the body's fluid systems made it a natural candidate for influence over conditions associated with excess phlegm and moisture, which tooth decay was thought to involve. The result was a multi-layered explanatory framework that combined humoral theory, astrological influence, and biological agency in the form of the worm, all organized around the central problem of why teeth hurt and how to make them stop. One of the genuinely interesting scholarly questions in the history of medieval dental theory is why the toothworm belief survived so long without the kind of empirical challenge that might have been expected to destabilize it. Historians still argue whether the persistence of the toothworm into the early modern period, despite the development of more sophisticated observational and anatomical tools during the Renaissance, represents a failure of the empirical tradition, a success of the theoretical tradition in assimilating contradictory evidence, or simply the deep inertia that established medical beliefs tend to develop when they have been institutionally and textually embedded for long enough. The eventual defeat of the toothworm theory, when it came not from a dramatic single refutation but from the gradual accumulation of anatomical knowledge that made its physical premises increasingly difficult to maintain. As dissection became more systematically practiced in the early modern period, and as microscopy allowed examination of dental tissue at increasingly fine scales, the physical evidence for the toothworm's existence became progressively harder to sustain. By the early 18th century, the French surgeon Pierre Fauchard, often called the father of modern dentistry, was able to state clearly that the toothworm did not exist and that tooth decay was caused by chemical processes rather than biological agents, and this statement, coming from someone with sufficient authority and evidence to support it, effectively ended the worm's 3,500-year run in serious medical discourse. Folk belief took longer, as folk belief always does, and there are documented cases of toothworm belief in rural European communities well into the 19th century, which is its own kind of testimonial to the extraordinary durability of the idea. But here, in the medieval world you are inhabiting tonight, the worm is real. Not real in the way you now understand real, not physically present in the cellular structure of the decayed tooth, not detectable by any instrument that exists in this century, but real in the more important sense that it is believed in by everyone around you, real in the sense that it shapes the treatments you will receive and the explanations you will be given and the framework within which your own experience of dental pain will be interpreted and understood. The worm is as real as the humors, as real as the astrological influences, as real as the healing power of Saint Apollonia's intercession. It is real in the way that all the organizing beliefs of a culture are real, as the structure that makes experience legible, that transforms raw sensation into something that can be named and addressed and, at least theoretically, resolved. You are pressing your tongue against the space where your tooth was and thinking about worms. Not with the skeptical distance of someone who knows that the worm does not exist, but with the particular intimate attention of someone who is trying to understand their own body through the best available interpretive tools. The socket aches. The fire has gone to coals. Somewhere in the dental interior of your jaw, something is happening that you do not have words for, that no one in your century has words for, and the toothworm is the closest available approximation, the placeholder theory that holds the space where better knowledge will eventually arrive. That is what wrong theories do when they are the best available theories. They hold the space. They organize the experience. They make the unbearable slightly more bearable by giving it a name and a shape and a treatment tradition. The worm in the tooth is wrong, but the impulse behind it, the need to understand what is happening inside your own body, to have a story that makes suffering make sense, is one of the most enduringly human impulses there is. Let the worm be the night's last image. Then, small and implausible and earnestly believed in, coiled in the dark interior of a medieval molar, doing its imaginary damage in a world that needed it to be there. The fire has gone down to almost nothing. The village breathes slowly around you. The worm keeps its own counsel, as invented things generally do, patient and persistent and magnificently, stubbornly wrong. The tooth worm kept its counsel and the medieval world kept losing teeth, and eventually, inevitably, with the particular human inevitability that transforms every problem into an opportunity for ingenuity, someone started thinking seriously about replacement. Not just about how to stop the pain, not just about how to remove the source of the infection, but about what came after removal, about the gap that extraction left behind, about the aesthetic and functional consequences of a mouth that was progressively emptying itself of the tools it needed to chew, to speak clearly, to present a face to the world that did not immediately advertise a history of dental catastrophe. The impulse to replace lost teeth is ancient. It predates the medieval period by centuries, with evidence of early dental prosthetics appearing in Etruscan and Roman archaeological contexts. But the medieval and early modern periods represent a particularly interesting chapter in this story, because the solutions that were developed during this era combine genuine ingenuity with ethical complications that become more uncomfortable the longer you look at them. Let us begin with what was available in terms of materials, because the material constraints on medieval tooth replacement shaped everything else about how it was attempted. The ideal tooth replacement material would be something that resembled natural tooth in color and texture, that was hard enough to function for chewing, that was biologically compatible with the surrounding tissues, and that could be shaped and fitted to the individual patient's mouth. Medieval craftsmen working on tooth replacement had access to none of the materials that modern denture technology uses. No acrylic resins, no metal alloys of the specific composition used in modern dental work, no precise casting techniques, no clinical understanding of how to design a prosthetic for optimal tissue compatibility. What they had was bone, ivory, wood, and natural teeth, human or animal, and the considerable traditional craft skill of the carvers and metalworkers who made things from these materials. Ivory was probably the most prized material for denture construction in the medieval period, and when we say ivory we mean specifically elephant ivory, which was imported into Europe along trade routes from Africa and Asia and was expensive enough to be a luxury material in its own right. Ivory is hard, can be carved to a reasonably smooth surface, has a color not entirely unlike tooth enamel, and is biologically inert in the sense that it does not rapidly degrade in the oral environment. Dentures carved from ivory, blocks of it shaped to approximate a row of teeth and fitted against the remaining natural teeth or the gums, were available to those who could afford them, which meant essentially the wealthy elite. They were not particularly comfortable, they did not fit with great precision, and ivory in the oral environment does eventually absorb moisture and begin to degrade, developing a yellowish color and a somewhat unpleasant odor over time. But they provided a functional and aesthetically reasonable approximation of teeth for people who could not otherwise present a complete smile, and for a wealthy person in the medieval period, the ability to present a complete smile was not a vanity. It was a social and political necessity. Bone was a cheaper alternative to ivory, more widely available and less expensive, though it shared many of ivory's limitations and had some additional ones. Oxbone, horsebone, and various other animal bones were carved into tooth forms and used in denture construction. And while they served the basic purpose of filling visible gaps, their fit, durability, and oral comfort were all limited. Wooden teeth, sometimes associated in popular imagination with George Washington, who did not, in fact, have wooden teeth, a persistent myth that has attached itself to him with remarkable durability, were used in various forms throughout the pre-modern period. Though wood's susceptibility to moisture absorption and decay made it a particularly poor material for oral use, and its use was probably more common as a temporary or emergency measure than as a long-term solution. All of these material solutions shared a fundamental limitation. They were static approximations of teeth rather than functional replacements for them. A carved ivory denture sitting against the gums could fill a visible gap and provide some assistance with certain types of food preparation, but it could not replicate the biting force or the precise occlusal relationship of natural teeth, and the absence of roots meant that no force could be applied through the denture to the jaw in the way that natural chewing transmits force through tooth roots into the supporting bone. Medieval denture wearers adapted their eating habits around their prosthetics rather than the prosthetics enabling fully normal function, which was a reasonable accommodation to an imperfect solution. The fitting of these early dentures was achieved through various methods. Some were wired to adjacent remaining natural teeth, a technique that placed considerable stress on those natural teeth and sometimes accelerated their own loosening and loss. Some were held in place by the patient's own muscular coordination and the slight suction created by a reasonably well-fitted base plate against the gum tissue, which required both a skilled fabricator and a patient with good neuromuscular control. Some were simply removed when eating and replaced for social occasions, functioning less as functional eating tools and more as cosmetic devices deployed for public presentation. There are accounts of medieval and early modern aristocrats managing their dining with careful attention to which foods could be consumed while wearing their dentures and which could not, navigating social meals with the particular vigilance of someone managing a complex technical constraint in a context where revealing that constraint would be socially costly. Now we arrive at the part of the medieval tooth replacement story that is the most interesting and the most ethically uncomfortable, and which requires a moment of framing before we get into the details. The most obvious potential source of replacement teeth that closely approximated natural teeth in every relevant way, color, texture, hardness, shape, the precise anatomy of actual human dentition, was actual human teeth. Not carved approximations of human teeth. The real thing. Human teeth extracted from human mouths and transplanted into someone else's, or human teeth harvested from the dead and incorporated into denture constructions that used real teeth rather than carved materials. The practice of using human teeth in tooth replacement is documented across the medieval and early modern period, and while it represents genuine ingenuity in the service of a real need, the social and ethical dimensions of where those teeth came from become rapidly uncomfortable when examined. Living tooth transplantation, the direct transfer of a tooth from one person's mouth to another's, was practiced in the early modern period with enough frequency to generate both practitioner enthusiasm and considerable scholarly literature. The procedure involved extracting a tooth from a donor and immediately transplanting it into the freshly prepared socket of the recipient, relying on the biological process of osseointegration to anchor the donor tooth in its new location. In theory, this could result in a functioning, natural-looking tooth anchored in the recipient's jaw. In practice, the success rate was highly variable, with many transplanted teeth failing to integrate and being rejected within months, and with the significant additional problem that transplantation carried a real risk of transmitting infectious disease from donor to recipient, including syphilis, which was not understood at the time as a transmissible infection and which several documented cases suggest was indeed transmitted through tooth transplantation procedures. The donor question is where the ethical dimension becomes acute. For successful living transplantation, you needed a fresh tooth from a living donor, which meant you needed someone willing to part with one of their teeth. The wealthy recipients of transplanted teeth did not typically donate their own teeth. The teeth came from people who needed money urgently enough that selling a tooth was a price they were willing to pay. The poor, the desperate, the young, for whom the financial transaction represented an economic calculation made under conditions that we would today recognize as coercive, even if the medieval and early modern framework did not apply that specific analysis. There are accounts of tooth vendors clustering around the practices of fashionable tooth pullers in early modern cities, available to provide fresh donor teeth on demand, and the social power differential between the fashionable clientele inside and the tooth vendors waiting outside requires no elaborate analysis to understand. The battlefield was another source. After major medieval battles, the bodies of the dead were a resource in multiple grim ways, and their teeth were among the things that surviving scavengers collected and sold. Waterloo teeth, a term that historically refers specifically to teeth harvested from soldiers killed at the Battle of Waterloo in 1815, though the practice it describes is considerably older, were used in denture construction throughout the 18th and into the 19th century, and the medieval and early modern period had its own version of this practice. The dead of plague outbreaks, of battles, of public executions, provided teeth that were harvested and sold into the denture trade, and the recipients of these teeth did not necessarily know or care about their provenance, which was a function of both the social distance between the tooth's previous owner and its new one and the practical invisibility of the supply chain. The construction of dentures using real human teeth either mounted individually on a base plate or incorporated into a mixed construction with ivory or bone, represented a genuine advance in dental prosthetics in terms of the naturalness of the result. Real teeth, properly mounted and fitted, could be indistinguishable from natural teeth in appearance in a way that carved ivory could not quite achieve. And for people whose social lives depended significantly on their physical presentation, this difference mattered. Upper-class women in particular, for the reasons discussed earlier regarding the social and political stakes of their physical appearance, were significant consumers of these high-quality prosthetics, and the industry that supplied them was, by the early modern period, sophisticated and commercially organized enough to represent a genuine market with supply chains and price structures and practitioner specializations. The mainstream historical fact here that anchors all of this is the development, in the late medieval and early modern period, of the first specialized dental practitioners, people who identified primarily as tooth-related specialists rather than as barber surgeons with dental skills. France was particularly important in this development, with Paris becoming a center of dental practice that began to develop both the practitioners and the institutional frameworks that would eventually evolve into modern dentistry. The title of expert pour les dents, expert for the teeth, appears in French records beginning in the 16th century, representing an early attempt to distinguish specialized dental practice from the broader barber surgeon tradition. The guild structures that governed skilled trades in medieval and early modern cities had complicated relationships with dental practice. Barber surgeon guilds claimed jurisdiction over tooth extraction as a surgical procedure. Apothecaries had interests in the dental remedy trade. The emerging specialist tooth treaters occupied an uncomfortable middle ground that was periodically the subject of guild disputes, licensing arguments, and jurisdictional conflicts that tell us a great deal about how medieval and early modern urban economies organized skilled labor, but are somewhat less illuminating about the actual practice of dental care. What the guild conflicts reveal, when you read between their legalistic lines, is that dental work was economically significant enough to be worth fighting over, that enough people were paying enough money for tooth-related services to make control of those services commercially important. There is a genuinely charming, quirky detail in the history of medieval and early modern dental prosthetics that deserves to be acknowledged: the hippopotamus. Hippopotamus ivory, the dense, hard material from hippopotamus teeth and tusks, was used as an alternative to elephant ivory in denture construction, and it had some advantages over elephant ivory in terms of hardness and resistance to the degradation that affected elephant ivory in the oral environment. Hippo ivory dentures were a real thing, commercially available to those who could afford them, and they represent a connection between medieval European dental practice and the African continent that you would not necessarily expect to encounter in this particular context. The global trade networks that brought spices and sugar and Arabic medical texts into medieval Europe also brought hippopotamus ivory for people's dentures, which is a reminder that medieval history is always more globally connected than the standard Eurocentric narrative suggests. The experience of wearing early medieval or early modern dentures was, by all available accounts, not comfortable. The fit was imprecise by modern standards. The materials were not optimally compatible with the oral environment. The mechanical relationship between upper and lower dentures, if both were being worn simultaneously, was not reliably stable. Eating with early dentures required adaptation and patience. Speaking with them required practice and attention. And maintaining them required the kind of careful cleaning and handling that their owners sometimes managed and sometimes did not, with consequences for the longevity and hygienic status of the prosthetics that varied accordingly. Yet people wore them. They wore them because the alternative, the visible, social, functional consequences of significant tooth loss, was worse than the considerable discomforts of early denture wearing. They wore them because human beings are remarkably adaptable and will accommodate significant inconvenience in the service of social participation and self-presentation. They wore them because the craftsmen who made them kept improving their techniques through accumulated experience, and each generation of prosthetics was somewhat better than the last, incrementally, imperfectly, but genuinely. They wore them because the desire to have teeth, to be a person who has teeth with all the social and functional dimensions that implies, is powerful enough to sustain significant effort and discomfort in its pursuit. You are lying in your medieval cottage thinking about all of this with your tongue exploring the space where your tooth was, and you are aware of a new kind of awareness that the extraction has produced, a heightened attention to the geography of your own mouth, The way your remaining teeth fit together, the specific topography of a mouth that is suddenly irrevocably changed. The socket is beginning to close. The blood has slowed. The absence is becoming familiar, as absences do, and already you are beginning to adapt to a mouth that is slightly different from the one you woke up with this morning. That adaptation is quintessentially human and quintessentially medieval, and it connects you, across all the centuries and all the distance, to every person who has ever sat with a fresh dental absence and felt their tongue move toward it with the particular involuntary curiosity that the newly missing always generates. The space where a tooth was is one of the most universal human experiences, and the impulse to fill it with ivory, with bone, with a stranger's tooth harvested from the aftermath of a battle, is one of the most persistently human responses to loss. The craftsmen who made those early dentures were not artists of the mouth in any grand sense. They were practical people solving practical problems with whatever came to hand, in the same spirit that has characterized almost every human technological advance from the beginning. The results were imperfect. They were also remarkable. They were the beginning of something that would take centuries to arrive at its modern form, but they were unmistakably the beginning. The craftsmen with their ivory and their bone were working in the visible, documented, institutionally recognized spaces of medieval medical practice. The guilds, the marketplaces, the court practitioners, the emerging specialist tooth treaters of the French cities. But there was another layer of dental care happening simultaneously, quieter and less visible in the historical record, operating through networks of knowledge transmission that left fewer written traces precisely because they were not organized around writing, because they passed through conversation and demonstration and intimate domestic instruction rather than through the Latin manuscripts and guild records that historians have traditionally mined for evidence about medieval medicine. This was the layer of care provided by women, by the healers, midwives, housewives, wise women, and domestic practitioners who managed the day-to-day health of their households and communities with a pharmacopoeia assembled from kitchen gardens and hedgerows and the accumulated empirical knowledge of generations. The role of women in medieval healthcare is one of the most actively researched and actively debated areas in the history of medicine, and for good reason. It was substantial, it was largely excluded from formal institutional recognition, and it has been significantly underrepresented in the historical narratives built primarily from sources produced by and for the literate male elite. Medical historians in recent decades have worked hard to recover this layer of practice, and while the recovery is necessarily incomplete, you cannot fully reconstruct an oral tradition from the fragmentary written traces it left behind. What has been recovered is enough to substantially complicate the picture of medieval healthcare as a story primarily about barber surgeons and university-trained physicians. Women were not absent from formal medieval medical practice. This is worth stating clearly, because the assumption of their total exclusion is itself a historical oversimplification. There were women who practiced medicine in some of the major medieval cities of Europe, particularly in southern Italy, where the medical school at Salerno had a tradition, extending back into the early medieval period, of women practitioners and possibly of women teachers. The figure of Trotula, associated with a set of influential medieval medical texts on women's health, represents, whatever the complicated questions about authorship and attribution that scholars continue to argue about, a documented tradition of women's medical knowledge being transmitted in written form and incorporated into the learned medical corpus of the medieval period. In the later medieval period, there are documented cases of women applying for and receiving licenses to practice medicine in various European cities, though such licenses were granted inconsistently, and the institutional barriers facing women in formal medical practice were real and significant. But the more significant contribution of women to medieval healthcare, and to dental care specifically, happened outside these formal institutional frameworks, in the spaces of domestic and community practice that formal medicine did not reach or did not bother to reach, which was most spaces, for most people most of the time. The village wise woman, the midwife who attended births and also managed the broader health of the women in her community, the housewife whose management of the household included the management of its members' health, the nun in her infirmary. These figures were the primary healthcare providers for the majority of the medieval population, and their practice included dental care in the broad sense of managing toothache, applying remedies, monitoring infections, and knowing when a situation had exceeded what home management could address. The specific contribution of women to dental remedy traditions is difficult to trace in precise detail, precisely because the knowledge moved through oral rather than written channels. But there are several points of access that allow us some purchase on what this tradition contained and how it functioned. One is the genre of household management texts that begins to appear in the later medieval and early modern period. Texts like the English Book of Nurture and similar continental European equivalents, which included health and medical information alongside guidance on cooking, estate management, and household organization. These texts often preserve remedies that their compilers had learned from female domestic tradition, and their dental content is revealing in its specificity and its practical orientation. The remedies preserved in this domestic tradition show a distinctive emphasis on materials that were genuinely available to ordinary households. The herbs of the kitchen garden, common household substances like salt and vinegar, animal products like butter and lard, familiar spices and aromatic plants. This is not the exotic pharmacopoeia of the learned physicians with their imported substances and their Arabic-derived formulations. It is the pharmacy of the larder and the garden, and it is in many ways more practically accessible and more reliably available than the learned tradition, because you did not need to buy or import anything exotic to deploy it. Sage appears repeatedly in these domestic dental traditions, recommended for gum health in ways that have some genuine empirical basis. Sage contains antimicrobial compounds that create a mildly hostile environment for certain oral bacteria, and rubbing the gums with fresh sage leaves is a genuinely reasonable folk dental hygiene practice. Salt in warm water, similarly, appears throughout domestic remedy traditions as a mouth rinse for gum inflammation and socket care after extraction, and as we have noted, this has real anti-inflammatory value even if the mechanism was not understood in those terms. Vinegar rinses appear in some traditions, which also has genuine antimicrobial properties, though the acidity that makes it antimicrobial also makes it potentially erosive to enamel with frequent use, a trade-off that domestic practitioners navigated empirically without any framework for understanding it. The management of children's dental health fell particularly within the female domestic sphere, and this is an area where the knowledge tradition has left some interesting traces. Teething, the eruption of primary teeth in infants and toddlers, was a recognized and significant health event in the medieval period, associated with a range of symptoms that medieval parents and practitioners took seriously and that modern pediatric medicine now understands rather differently. Medieval medical tradition, drawing on both learned sources and folk practice, associated teething with fever, digestive upset, skin rashes, and other systemic symptoms in ways that modern evidence does not support. The fever and illness that medieval observers associated with teething were probably coincidental concurrent illnesses rather than direct consequences of tooth eruption, but the practical responses that women developed for managing teething discomfort were often reasonable on their own terms. Teething rings made from hard materials that the infant could bite against, recorded in various forms across different medieval and early modern traditions, represent the same basic insight that underlies modern teething toys, that the discomfort of tooth eruption is relieved by counterpressure, by something firm to bite on. The specific materials recommended varied. Coral was favored in wealthier households for reasons that combined genuine hardness with symbolic and magical associations attributed to coral's supposed protective properties, while cheaper alternatives included harder woods, bone, and other firm materials. Rubbing the gums with various substances, honey, butter, the juice of specific plants, was another common approach. And here again we see the combination of genuinely soothing properties with pharmacologically active compounds in a mixture that probably helped somewhat even if its effectiveness was attributed to the wrong mechanisms. The transmission of this knowledge across generations was primarily female and primarily oral, and it happened in the specific physical contexts of women's domestic work, at the hearth, in the lying-in chamber where women attended births, in the spaces of collaborative female labor that medieval social organization created and that provided the infrastructure for an extensive informal knowledge economy. A young woman learning to manage a household learned dental remedies alongside cooking techniques and textile production and the management of domestic animals, not as a separate category of medical knowledge but as part of the integrated practical knowledge that household management required. This integration is itself significant. It meant that dental care in the domestic female tradition was never separated from its social and nutritional context in the way that formal medicine tended to separate it. The woman who knew which herbs helped with toothache also knew what foods were available in her household and what remedies were locally accessible, and she prescribed accordingly. The wise woman figure, the practitioner who stood at the outer edge of this domestic tradition, serving a broader community rather than just her own household, occupied a complex social position that varied significantly by time, place, and the specific configuration of ecclesiastical and secular authority in her community. At her most benign and most accepted, the wise woman was a valued community resource, the person you went to with problems that could not wait for a professional and that required someone with more knowledge than an ordinary household possessed. At her most suspected and most persecuted, she was the target of accusations of witchcraft that represented the intersection of gender, unauthorized knowledge, and the institutional suspicion of unregulated practice that ran through medieval and early modern European culture with persistent and sometimes violent force. The relationship between the wise woman tradition and the formal medical establishment was not simply one of suppression. It was more complicated than that, involving various forms of negotiation, incorporation, and mutual influence that historians are still tracing. Some learned physicians drew on folk traditions in their own practice without necessarily acknowledging the source. Some formal medical texts included remedies that had clearly originated in folk tradition even if they presented them within a learned theoretical framework. Some wise women had access to written medical texts and incorporated elements of learned medicine into their practice. The boundaries between official and unofficial, learned and folk, male and female in medieval medical practice were real but permeable, and the flow of knowledge across them moved in multiple directions. The Church's relationship with female folk healing was similarly complicated. On one hand, the institutional Church was deeply suspicious of unauthorized healing practices, particularly those that involved elements that looked like magic rather than prayer, and this suspicion fell disproportionately on women practitioners whose work was less visible and less officially sanctioned than that of male professionals. On the other hand, the Church itself operated extensive healthcare facilities through its monasteries and convents, staffed significantly by women who provided nursing care, managed herbal preparations, and delivered a range of practical medical services to the sick poor. The abbess of a major convent might oversee a sophisticated infirmary with a well-developed medical tradition, drawing on both written sources and accumulated practical experience, representing an institutionally recognized form of female medical authority that coexisted somewhat uneasily with the suspicion directed at the informal wise woman tradition. Hildegard of Bingen, the remarkable 12th-century German abbess, theologian, composer, and natural philosopher, wrote extensively on medical topics including dental health, and her work represents one of the most interesting points of intersection between female religious authority, learned medicine, and folk knowledge in the entire medieval period. Her medical writings include specific observations about dental disease and its remedies that combine the theoretical framework of her time with what appears to be genuine practical observation, and she represents, whatever the questions about the precise nature and sources of her medical knowledge that scholars continue to debate, a documented instance of a woman contributing substantively to the written medical tradition of the medieval period rather than simply operating outside it. Historians still argue about the degree to which Hildegard's dental and medical observations reflect original empirical observation on her part versus compilation and synthesis of existing written sources, and the answer is probably that it was a mixture of both, which is true of most medical writing in any period. What is less contested is the significance of her work as evidence that the boundary between female domestic medical knowledge and the learned medical tradition was not absolute, and that the two could meet in the person of an individual practitioner with both the access to written sources and the practical engagement with health management that her institutional position provided. The dental remedies that appear in Hildegard's writings and in the broader tradition of female-authored or female-transmitted medical knowledge have a distinctive character when compared to the mainstream learned tradition. They tend to be more pragmatic and less theoretically elaborated, less concerned with explaining why a remedy works in terms of humoral theory or astrological correspondence, more focused on what to do and how to do it. They tend to use locally available materials more and expensive imported substances less. They tend to address the full range of dental situations from prevention to acute pain management to post-extraction care in a more integrated way, reflecting the reality that a domestic healer managing a household's dental health had to cover the full spectrum rather than specializing in any particular intervention. The emphasis on prevention in the female domestic tradition is particularly striking when compared to the reactive orientation of much formal medieval dental practice. The formal medical establishment largely addressed dental problems after they had developed. You went to the barber surgeon when the tooth needed to come out, you consulted the physician when the pain was acute, you sent for the tooth puller when the situation had reached crisis. The domestic tradition, by contrast, included an extensive repertoire of preventive practices, regular mouth rinsing, teeth cleaning with various preparations, attention to diet, specific practices associated with different life stages that represented a genuine attempt to maintain dental health rather than simply managing its deterioration. This preventive orientation makes a kind of practical sense when you consider the context. The domestic healer could not perform extractions, could not deploy the full range of pharmaceutical interventions available to a formally trained practitioner, and was working primarily through the slower, more diffuse mechanisms of diet, hygiene, and mild pharmacological intervention. Prevention was what she had to offer that the formal tradition did not emphasize, and she offered it with considerable ingenuity and accumulated practical knowledge. Tonight, in your imagined medieval village, there is a woman in the house next to yours who knows more about maintaining dental health than the barber surgeon who extracted your tooth this morning. Not because she is better trained in any formal sense. She has no formal training at all, no guild membership, no license. But because she has been paying attention for decades, to her own mouth and her children's mouths and her neighbors' mouths, to what helps and what hurts and what the difference is between a situation that can be managed at home and one that requires more drastic intervention. She has a garden full of sage and a jar of salt and several preparations she has made from recipes her grandmother gave her, and she knows, with the empirical confidence of long practice, which of them to reach for in which circumstances. She also knows that the best dental care she can offer is the kind that means nobody needs to go to the barber surgeon in the first place. She knows this not as a theoretical principle but as a practical reality, earned through years of watching what happens when people do and do not attend to their mouths with care and consistency. She is the person who will tell your children how to clean their teeth, what to eat and what to avoid, what to rinse with and when, how to notice the early signs of trouble before trouble becomes crisis. She is, in this specific and important sense, doing dentistry even though she does not have a name for what she does, even though no guild will recognize her expertise, even though her knowledge will leave no written trace and will survive only if her daughters and granddaughters are paying attention. They usually were. That is how it got this far. The woman next door with her sage garden and her grandmother's recipes represents a kind of knowledge that moves through time differently from the knowledge preserved in manuscripts and guild records. Slower in some ways, faster in others, more distributed, more resilient to the kinds of institutional disruption that periodically erased or fragmented the formal medical tradition. Her knowledge would outlast kingdoms and survive plagues and cross oceans in the memories of emigrants who packed their practical domestic wisdom alongside whatever else they could carry. But it would also, gradually and unevenly, begin to intersect more deliberately with the formal tradition. And that intersection, messy and contested and full of the kinds of conflict that attend any meeting between established authority and unauthorized competence, is the story of how medieval dental practice began its long, slow transformation into something that would eventually, centuries later, become recognizable as modern dentistry. The transformation was not a single event and it did not have a single cause. It was a process that unfolded across several centuries, driven by a convergence of factors that included the recovery and reinterpretation of ancient medical texts during the Renaissance, the development of more systematic anatomical knowledge through the gradual normalization of human dissection, the growth of urban commercial economies that created both demand for specialist services and the infrastructure to support specialist practitioners, and the specific intellectual culture of the early modern period that increasingly valued empirical observation alongside theoretical inheritance. None of these factors was primarily about dental care. All of them affected it. The Renaissance recovery of ancient texts had a complicated effect on medical practice in general and dental practice in particular. On one hand, the humanist project of returning to original classical sources rather than medieval summaries and commentaries brought European scholars into contact with more sophisticated versions of ancient medical theory than had been available through medieval transmission. On the other hand, the reverence for ancient authority that characterized Renaissance humanism could sometimes function as a brake on innovation, encouraging practitioners to seek better interpretations of ancient texts rather than questioning whether those texts had gotten things fundamentally right. The toothworm, as we noted, survived this period of classical recovery largely intact, because the ancient texts that Renaissance scholars were recovering with such enthusiasm also contained the toothworm, presented with the authority of Sumerian and Egyptian and Greek antiquity. What began to crack the theoretical framework of medieval dental medicine was not primarily the recovery of better ancient texts, but the development of direct anatomical observation as a legitimate and valued form of medical knowledge. Andreas Vesalius, the Flemish anatomist whose great work on human anatomy, published in 1543, represented a decisive turn toward empirical observation in European medicine, included detailed attention to dental anatomy that was more accurate than anything in the medieval tradition, based as it was on actual dissection of human subjects rather than on the inherited theoretical frameworks of Galenic medicine. Vesalius did not specifically refute medieval dental theory. His interests were primarily structural and anatomical rather than pathological, but the methodological revolution his work represented created the intellectual conditions within which later investigators could bring the same empirical rigor to questions of dental disease and treatment. The figure who most clearly embodies the transition from medieval to modern dentistry is Pierre Fauchard, the French surgeon who published Le Chirurgien Dentiste, the Surgeon Dentist, in 1728, and who is conventionally described as the father of modern dentistry. Fauchard's book was a systematic, comprehensive treatise on dental disease, dental anatomy, and dental treatment that drew on his own extensive clinical experience, and that explicitly rejected several of the central theoretical pillars of medieval dental medicine, including, definitively, the toothworm. Fauchard was the person who stated clearly, and with sufficient authority to be taken seriously, that there were no worms in teeth, that dental decay was caused by chemical processes rather than biological agents, and that effective dental treatment required precise anatomical knowledge and technically refined interventions rather than the theoretical elaborations of humoral medicine. But Fauchard did not appear from nowhere, and the road from the medieval barber surgeon to the 18th century surgeon dentist was longer and more interesting than the standard narrative of a single founding figure suggests. The 17th century, in particular, was a period of significant development in dental practice, even though it does not have a single iconic figure comparable to Fauchard. Urban dental practice in the major European cities became more sophisticated during this period, with practitioners developing improved extraction techniques, more refined prosthetic constructions, and a more empirically grounded understanding of dental anatomy. The French surgical tradition, which had been developing institutional coherence since the later medieval period, was particularly active in this development, and Paris in the 17th century was home to practitioners whose work directly influenced Fauchard and whose accumulated clinical knowledge formed the practical foundation on which his theoretical synthesis was built. The development of dental instruments during the late medieval and early modern period also represents a genuine and continuous thread of technical improvement that is easy to overlook if you are focused on the theoretical breakthroughs. The pelican and the dental key were not static objects. They were continuously refined by the craftsmen who made them and the practitioners who used them, with each generation of instruments incorporating small improvements in leverage geometry, in the fit of claws and bolsters, in the handle design that determined how much control the operator had during the procedure. These improvements were incremental and undramatic, nowhere near as visible as a theoretical revolution, but they represent the kind of practical technical progress that ultimately determines whether patients survive their dental encounters more often and in better condition than before. Historians still argue about the precise relationship between formal and informal medical practice in driving the improvements in dental care that occurred between the medieval period and the early modern one. Some emphasize the role of the emerging surgical and dental elite, the practitioners who wrote books, who trained apprentices in formalized settings, who engaged with the broader learned medical tradition, as the primary agents of improvement. Others point to the accumulated practical knowledge of ordinary practitioners, the barber surgeons and tooth pullers and wise women whose empirical trial and error across thousands of patient encounters generated the practical knowledge base from which formal advances were ultimately drawn. The truth is almost certainly that both contributed, that the formal and informal traditions were more porous to each other than either self-presentation suggested, and that the history of dental improvement in this period cannot be told as the story of either tradition alone. The patients, of course, rarely appear in this history except as the recipients of other people's expertise, and yet they were also, in a real sense, agents of change. Patient demand shaped the development of dental practice in ways that are easy to underestimate. The demand for effective tooth replacement drove the development of prosthetic techniques. The demand for less traumatic extraction drove refinements in extraction instruments and technique. The demand for practitioners who could reliably manage dental pain without making things catastrophically worse created the competitive pressure that drove practitioner improvement. Medieval and early modern patients were not passive recipients of whatever dental care their society offered. They had opinions. They had preferences. They went back to practitioners who helped them and avoided ones who did not. They shared information about whose remedies worked and whose extraction technique left them worse off. They were, in the economic sense, consumers of dental services, and the market they constituted shaped the services it received. The mainstream historical fact that anchors this section is one of the most quietly remarkable in the entire history of dentistry: the formal separation of dental practice from general surgery, which occurred in France in 1699 when a royal edict established a licensing requirement for tooth operators that was separate from the surgical guild. This represents the first formal legal recognition of dentistry as a distinct specialty rather than a subset of surgery or barbering, and it marks, as clearly as any single institutional moment can mark a gradual process, the emergence of dentistry as a profession with its own identity, its own standards, and its own claim to a distinct body of knowledge. The road from that 1699 edict to the modern dental profession is much shorter and straighter than the road from the medieval barber surgeon to 1699, and that later road is better documented and more conventionally told. What we carry forward from the medieval period into modern dentistry is more than the standard narrative of superseded ignorance suggests. The empirical identification of effective analgesic plants, clove, willow, pellitory, henbane, fed directly into the development of the modern dental pharmacopoeia through the early modern period of botanical medicine and pharmacological investigation. The basic mechanical principles of the dental instruments developed in the medieval and early modern period, leverage, controlled force, the importance of root anatomy in determining extraction approach, are still recognizable in modern extraction technique. However, dramatically, the specific instruments have been refined. The understanding that dental health requires ongoing maintenance rather than simply reactive intervention, which was present in both the learned tradition and the female domestic tradition of the medieval period, is the foundational insight of modern preventive dentistry. The architecture of the medieval dental world, its practitioners, its remedies, its theories, its patients, has been absorbed into the modern dental world in the way that all historical foundations are absorbed, invisibly, structurally, present in the shape of things even when the surface materials have been completely replaced. You sit in a modern dental chair that is a direct descendant of the barber surgeon's bench, operated by a professional whose guild lineage traces back to the medieval craft organizations, using instruments whose design principles were worked out over centuries of empirical refinement, receiving care organized around the understanding that teeth matter and that losing them has consequences worth preventing. The medieval world is in that chair with you, patient and ancient and largely invisible, as all good foundations are. The specific experience of dental care has, of course, changed beyond anything a medieval patient could have imagined. The local anesthetic injection that numbs your jaw before the modern dentist begins work is perhaps the single most consequential innovation in the entire history of dental practice, more transformative in its effect on the patient experience than any other single development. The moment in the mid-19th century when practitioners began using chemical anesthesia for dental procedures, nitrous oxide, then ether, then the development of injectable local anesthetics in the early 20th century, represents a genuine discontinuity. A before and after that divides the entire history of dental care into two qualitatively different periods. Everything before anesthesia is dental care conducted against a background of pain. Everything after is dental care conducted, at least in principle, in the absence of pain. That difference is so fundamental that it almost makes the two eras incomparable. And yet they are comparable because the people in both eras were the same in all the ways that matter, motivated by the same desire to be free of pain, navigating the same anxiety about dental procedures, making the same calculations about when the discomfort of treatment was worth accepting to avoid the greater discomfort of leaving a problem untreated. The medieval patient pressing a clove against an aching tooth and the modern patient calculating whether to call the dentist today or wait and see if it gets better are responding to the same fundamental situation with the specific tools their respective centuries provide. The tools are incomparably different. The situation is the same. What the medieval dental world ultimately teaches us, if we let it, is something about human persistence and human ingenuity and the remarkable capacity of people to develop workable responses to genuinely difficult problems with whatever happens to be available. The rat skull didn't work. The tooth worm didn't exist. The humoral theory was wrong from the foundations. And yet the medieval dental world produced clove oil and willow bark and the basic mechanical principles of extraction and the first professional dental organizations and an extensive tradition of preventive domestic care and the empirical knowledge base on which the modern profession was eventually built. Wrong about the theory, right about the need, ingenious in the response. That is not nothing. That is, in fact, everything. And now we are coming to the end of our journey through the medieval mouth, and it is time to let the centuries drift back into the comfortable distance from which history is best appreciated. Not too close, where it becomes overwhelming, and not too far, where it loses its texture and its humanity, but at exactly the right distance where it is strange enough to be interesting and familiar enough to be moving. You have been, tonight, a medieval villager with a toothache. You have sat on the barber surgeon's bench and felt the pelican's leverage against your jaw. You have held cloves against your aching molar and said prayers to Saint Apollonia and listened to the theories about tooth worms with the sincere attention of someone who has no better explanation available. You have eaten the grain-heavy diet that set your teeth up for trouble and the sugar-sweetened preparations that the physician prescribed as medicine. You have been the baron with the blackened teeth and the peasant with the worn-down ones, and you have understood, from the inside, that the great equalizer was not death but dental pain, shared impartially across all the social strata of the medieval world. Let all of that settle now, gently, like sediment in still water. Let the medieval village dissolve back into the soft darkness from which it came. The wood smoke is fading. The barber surgeon has closed his shop. The wise woman next door is sleeping, her garden quiet under whatever moon the medieval sky is offering tonight. You are here now in your own bed, in your own century, with access to anesthesia and antibiotics and precisely manufactured instruments and a dentist whose phone number you can find in seconds. You have things that the most powerful monarch in the medieval world would have given significant portions of their kingdom to possess. You have them so completely and so routinely that you do not think about them, which is fine. That is what it means for something to be ordinary, to be the unremarkable background of a life rather than a precious foreground exception. But tonight you thought about them briefly in the warm and drifting way that bedtime history makes possible. Tonight the dental chair was briefly medieval, the anesthetic briefly miraculous, the simple fact of effective pain relief briefly extraordinary. Tonight the clove oil on someone's ancient toothache connected, across 800 years, to the eugenol in your dentist's cabinet, and the thread between them was visible for a moment before it faded back into the ordinary fabric of things. That thread is always there. History is always there, structural and invisible, holding the present in its shape. The medieval barber surgeon did not know he was building toward your dental appointment, did not know that his pelican would evolve into your dentist's forceps, did not know that the tooth he pulled with such determined effort on that long-ago morning would be connected, through 8 centuries of accumulated ingenuity and error and correction, to the chair you will sit in next time a tooth gives you trouble. He just did his work, as well as he could, with what he had. That is enough. It has always been enough. Let your jaw unclench now, completely and finally, and feel the luxury of a mouth that is, right now, not in pain. Feel the weight of your pillow and the warmth of your blanket and the soft rhythm of your own breathing, which has slowed to something very close to sleep while you were traveling through the centuries. The medieval world is receding. Your own world is close and warm around you. There is nothing left to think about tonight that cannot wait until morning. The barber surgeon is closing his shutters. The wise woman's fire is the last light in the village. The tooth worm sleeps in its imaginary tooth, patient and fictional, dreaming whatever it is that medieval misconceptions dream of on quiet nights when the pain has finally, mercifully eased. So does the village. So do you.